very warm welcome to all of you, starting with our speakers and participants, also our viewers from various social media platforms. We welcome you to the very first Pan-African Conference on Hypertensive Disorders in Pregnancy. Our theme for this year is quality of care, where we will be focusing on the strategies that can be used to achieve optimal intervention for the prediction, diagnosis, and management of hypertensive disorders in pregnancy, particularly in our African continent. We already know that it is a huge challenge to have quality care administered to high risk and even other patients suffering from hypertensive disorders in pregnancy in Africa. So we believe that with this conference, we will be able to share ideas on how to overcome some of those challenges. What will be more befitting, of course, to host our very first conference other than on the World Preeclampsia Day. So with this, I welcome you all and thank you for your time that you took to join us in this webinar. We would also like to take this moment to thank the official organizers of the conference, which is Zurin Zidani Foundation based in Kenya and Action on Preeclampsia Ghana, and also including the people that are involved in the sports studies. We really appreciate their efforts that they put into promoting awareness around hypertensive disorders in pregnancy in their communities, which is contributing highly to the saving of our mothers and babies' lives. So starting with the welcome, I've already welcomed all the participants, the speakers, and our viewers on social media. For those who are now in the conference, we would kindly like to get to know you better. So you are more than welcome to write in the chat and answer the following 4 questions for us. First, let us know where you are joining us from, what your professional background is. Then indicate to us also what is driving you or your interest in hypertensive disorders of pregnancy in Africa or wherever you are globally. And then last point, please just indicate to us what are your expectations for this conference? What would you like to learn? What would you like to be your take-home message today? So please do that. I will be looking in the chat to see where everyone is from, and then just mention your answers to the rest of the group. Okay, this is great. We have a lot of participants, even out of Africa. See someone from Australia, Ghana, Accra, Netherlands, great, UK. So we also have some good representation from outside our continent, Denmark, Tanzania, Kenya. And we also have a variety of professions. We have midwives, medical doctors, PhD candidates, researchers. Oh, great. We also have pastors, wonderful. A really multidisciplinary team here, pharmacists. Okay, with the professions, we also see that really we have people representing various stakeholders, which are all very important if we are going to achieve the quality of care in managing hypertensive disorders of pregnancy. And if we look at the expectations, it's people are excited to learn more about PE management in different contexts, and obviously to contribute to the current research that they are doing in their own countries. And I see people would like to know how to improve their knowledge on and hopefully skills on the management of hypertension in pregnancy. Yes, so it's mostly about care. We all want to know how to improve care. Great to see. Yes, great to see people joining from Copenhagen. Yes, it's good to see all these people joining in from other places in the world. Shows the interest in the common cause to save our mothers and babies, and hopefully build future collaborations to work across borders. Yes. Improving midwifery care for women who develop preeclampsia, great. Yes, and another important point that is coming out from the expectations is people would like to know how to manage hypertensive disorders, not only during pregnancy, but before that, and what happens after pregnancy. This is very important because the quality of care or the holistic approach must include all these factors. So I believe that some of our speakers will cover that and meet all these expectations. I'm going to give some more time for people to post their questions. Okay, seems like we've got most of the answers that we needed for this question. So we know that where most of the people are coming from, and we know that we have people coming from various backgrounds who are interested in hypertensive disorders in pregnancy. And then we also have an overall presentation of what expectations are needed for which expectations people have for this conference. So with that in mind, we'll move to the next item on the agenda. So as you can see, we have a very exciting agenda. It's packed, but overall, the themes that we will cover, obviously, we'll start with the solidarity messages, go to the stories of hope, and then we will have a global perspective on maternal health, and then look at ways in which we can improve the quality of care in our communities, in the hospitals, then have a question and answer session. After that, we'll move to the non-communicable diseases, still focusing on hypertensive disorders of pregnancy. And then, of course, we cannot leave out the critical point here, which is the impact of COVID-19 in response to treatment and care for high-risk patients experiencing hypertension. So that's overall what the program will be about. With that, we will now move to the solidarity messages, which will be introduced by Ms. Isabella Cathy. Over to you, Isabella.
Thank you, Lebo, and thank you everyone for joining us today. We are really glad to have you here, really exciting. We have two solidarity messages. First, we'll listen to a message from Dr. Green, and then we'll also take another message from the Northwest University. So Gina, can you play the video, please?
Hello, my name is Marcus Green. I'm the Chief Executive of Action on Preeclampsia in the United Kingdom, and I could not be more happy and more delighted to be here this afternoon supporting the Pan-African Conference on Hypertensive Disorders of Pregnancy, which has been organised by Action on Preeclampsia Ghana and the Zuri Nizlani Foundation. You are doing wonderful work in Africa. You're doing wonderful work in Ghana, and I wanted to spend a couple of moments telling you about what we're doing in the United Kingdom as we approach our 30th anniversary next year. We work with women throughout the United Kingdom. We work on three particular areas. The first of those is support. We are here to give support to women, here to give support to their families, and to answer questions and provide them with information about preeclampsia, about HELLP syndrome, and about the associated hypertensive disorders of pregnancy. We do this through our website, through social media, through our helpline, and through an expert referral program. So women who are struggling, women who are going through a difficult time, can be referred to an expert who hopefully will be able to help them and set them in the right direction. We're also involved in education. We have an online training resource which you can all access at apec.org.uk, which is a multi-unit course where you can access it and you can find out more about pregnancy hypertension and about preeclampsia. Finally, we're involved in a lot of research. We're involved in research across the United Kingdom, and each part of the research that we're doing is looking for that next piece of the jigsaw which will help us to understand preeclampsia more and stop the blight on so many women and so many of their pregnancies. Recently, we have launched a new group for partners of those who've had preeclampsia, and so we continue to work and continue to find new ways of engaging with people. Now today, I could not be more happy. One of the things we have been engaged with in the last few years is overseas work. And the work that you are doing in Ghana and now across Africa is unparalleled, excellent, and really is helping women. I'm so pleased today that you're holding this conference. I'm so pleased that you've got an excellent range of speakers. Earlier this week, I was at the APEC International Conference, and we heard Koiwa speak about the founding of APEC in Ghana, about the work that you've done, about how you've got regional coordinators, about how you've got over 100 volunteers. This is a fantastic achievement in a small organization which has not been going that long, and you should be very, very pleased with what you are doing. But there is a strong message here, and there is a strong message for other women, other countries, and other organizations. And that is what can be done in Ghana, can be done in Ethiopia, can be done in South Africa, can be done in Egypt, and throughout the continent of Africa. We know that the most deaths from preeclampsia take place in Africa and India. We know that it is a significant killer, and we know that you are losing too many babies as well. Therefore, the work that you are doing, the time that you are spending on creating new organizations and raising public awareness and driving engagement is so important. I couldn't be more proud of what you're doing, and I'm delighted to support everything that is going on today. I think you have a fantastic conference lined up. I really am looking forward to hearing some of the speakers today and getting involved and understanding more about some of the issues. At APEC, we have worked with our chairman, Professor Andrew Shannon, who is a leader in global health, and he has set up APEC International. You can find the website at apecint.org, and I would urge you to have a look at that and see what the resources are that might be of use to you. Feel free to help yourselves and take whatever you would like. Also, please take anything you like from apec.org.uk. You're welcome to it. These resources are well thought out and can be of help to all of you. Finally, I'd like to reiterate what I said at the beginning. This conference, a Pan-African Congress on Hypertensive Disorders of Pregnancy, is a superb achievement. You have done a brilliant thing, and I could not be more impressed with what you are doing. It's a great achievement, and I hope you have a fantastic conference today, and it comes with the best wishes of all of us in APEC in the United Kingdom. Thank you very much.
I would like to reintroduce myself again. My name is Leboga Fani Matemani. I am from Northwest University Hypertension in Africa Research Team, and I will be presenting our message of support for this conference on behalf of our research unit. So Hypertension in Africa Research Team is a center of excellence at Northwest University, South Africa. We are the South African Medical Research Council extramural unit for hypertension and cardiovascular disease, and also host the South African Chair Initiative on Early Detection and Prevention of Cardiovascular Disease in South Africa. We run several projects to investigate cardiovascular risk factors in Africans, and I can also just add that we have observed in our studies that women, even at a younger age, seem to present with a higher risk for cardiovascular disease when looking at biological factors that contribute to cardiovascular disease development, including most importantly and of relevance today, hypertension. So as a team, we are also involved in the International Society of Hypertension's initiative on hypertension awareness, which is known as the May Measurement Month. What we have learned from being involved in that campaign is that awareness campaigns contribute a lot, tremendously, to increasing screening levels and referrals for people with high blood pressure. It is in the same spirit that Hypertension in Africa Research Team supports wholeheartedly the action on preeclampsia Ghana and their collaborators with regards to their advocacy work, this conference, and all activities that they are involved in to try and combat the scourge of hypertensive disorders of pregnancy that is affecting African women, their families, and communities at large. We believe that by reaching out to our people, sharing our stories in a language that they understand, and engaging our various community stakeholders, giving consideration to the cultural and religious aspects can really help with eliminating some of the barriers that are challenging to achieve quality or optimal care for hypertensive disorders in pregnancy. Thank you. That's the message from Hypertension in Africa Research Team. So now we will immediately go to the stories of hope to further increase awareness around hypertensive disorders of pregnancy. And with that, we will give the stage to Ms. Ashley Mutati. Ashley is part of the Zurin Zilani Foundation, which is playing a huge role in organization of this conference. And being a survivor herself, she's going to share with us her story, which we hope will be able to touch many people's lives and further encourage everyone to do the little that they can be able to do to promote, even at our homes, in our communities, people that are not in our fields, to share the stories with them, to finally at some point achieve a level where most of the people are aware about the different hypertensive disorders of pregnancy, and they know what to do about that, because sometimes people are not taking any action, not because they are ignorant, but for the lack of information. So these stories, I hope, will go far and beyond the conference into communities that need to hear them. Ashley, over to you. Thank you.
My name is Ashley Mutati. I am a mother and founder and executive director at Zurin Zilani Foundation. Zurin Zilani Foundation is a foundation that creates awareness on hypertensive disorders of pregnancy and offers support to mothers and survivors of preeclampsia here in Kenya. The organization was started based on my own experience in 2018 and 2019, whereby I experienced preeclampsia, one in which I unfortunately lost my baby. And my experience in with preeclampsia, if I can say, is it started just at 26 weeks. Personally, I didn't know about preeclampsia. I've never heard about hypertension in pregnancy. I've never seen anyone go through hypertension in pregnancy. And so I was not aware, and I went through the pregnancy period with preeclampsia, but I didn't know about it. However, it was picked up at 26 weeks. And unfortunately, I lost my baby at 30 weeks after delivery. She stayed in NICU for 2 months, and unfortunately, she lost the battle due to neck. The doctors had warned me not to get pregnant again. And it was pretty bad, because I went through a very severe case of preeclampsia, which made me get admitted 1 month in hospital. So after that, sorry, I'm a bit anxious, but it's okay. So after that, the doctors had warned me about it, and I got pregnant 4 months after the surgery. And the doctors gave me the option to either terminate the baby or have pregnancy under high risk. And so I chose to have the pregnancy under high risk. And I went through severe, what is it called? Placenta abruption that happened at 7 months of pregnancy, and I had to deliver the baby. The baby got delivered at 975 grams. And I'm happy that now she just turned 2 years old. So I'm happy that she survived the ordeal. And the reason as to why I started Zurin Zilani Foundation here in Kenya is because, number one, I didn't have any information about preeclampsia or hypertensive disorders of pregnancy. And no one could tell me, apart from the hospital where they gave me a few information, but I didn't really know the entirety of this particular condition. And so I said, this thing is killing a lot of women, because when I was in hospital, 7 out of 10 of the women who came in and gave birth prematurely had preeclampsia, and they didn't know about it. And so I really wanted to play a part in contributing to the community and my community here in Kenya by creating awareness about this particular condition. And so that's why Zurin Zilani Foundation started, and it started in 2019. So we've done close to 2 years of work. Our work centers around training, research, advocacy, and social support. We have a group of women who have gone through preeclampsia and who are currently going through preeclampsia. our aim is to create awareness because we've experienced quite a number of challenges here in Kenya. One of the challenges being there's lack of information on preeclampsia. We've experienced a number of women coming in to our support groups, and when they were told they had preeclampsia and protein in their urine, they went home and stopped taking protein. And this particular lady lost her baby last year in January because she went home and stopped taking protein, and the hospital where she went for to be checked did not tell or did not give her enough information about the condition that she was suffering from. So for us, our duty is to really create awareness and do a lot of trainings during antenatal clinics, and also training of healthcare workers to know how best to be able to treat women who are coming in with this high-risk pregnancy condition. And so I'm very happy that we are partners in doing this particular conference. I am happy for every single person who has taken their time to join in, and all the speakers who have taken their time to join in. And I take this opportunity to say thank you very much. And I hope moving forward, we will move as Africa and move towards the goal of sensitizing women because of early detection and treatment can be able to save lives. Thank you very much.
Thank you very much, Ashley, for sharing your story with us. It's touching. And I mean, some of the recommendations or the suggestions you made in your talk, I could not emphasize them enough to say we need to sensitize our communities. We need to sensitize women. This matter must be known even by women who are not yet pregnant. They're still young in future. They would like to get pregnant. The families, people who support these women, the husbands, we need to sensitize everyone, because it's not a responsibility for only women or for the healthcare providers. Everyone is responsible, because these women, they live in the communities, they live with families, they live with friends. So the main aim here and the message that I'm getting from Ashley's story is that awareness plays a huge role. I mean, just looking at the numbers at the hospital that she was admitted at, 7 out of 10 women, that's alarming. It shows the agency that we need to treat hypertensive disorders of pregnancy with. And she also highlighted one important thing when she was talking about care. She mentioned how best to care for these women, because we have healthcare systems, but it's not clear what's the best way, which guidelines are the best to follow. When is it the best time to intervene? So I believe that our speakers will allude to all those factors, some of them in their talks and also during the panel discussions, so that we can all go out of here with very important information that we can use. So now I'm going to take this moment to introduce our next speaker. Our next speaker, which is in fact our guest speaker, Dr. Laura Meji. Thank you very much for joining us. So Dr. Laura is a general obstetric internist at Royal College of Canada and a fellow at Royal College of Obstetricians and Gynecologist in the United Kingdom. She joined King's College London as a professor of women's health, following consulting posts at St. George's University London, also in the UK, and the Universities of British Columbia and Toronto, Canada. Dr. Laura's research is focused on pregnancy and hypertension, particularly antihypertensive therapy. She is the president of the International Society of Hypertension in Pregnancy and chair of Maternal Medicine Clinical Study Group of the Royal College of Obstetricians and Gynecologists in the United Kingdom. Dr. Laura, thank you very much for your time. The floor is yours.
Thank you very much. I will just get my slides up. Well, happy World Preeclampsia Day. Thank you so much for both mounting the program and for including me in it. And I just want to say that it's an honor to follow on from Ashley and the very powerful messages that you have shared with us. My name is Laura McGee. I'm a professor of women's health at King's College London. My passion is hypertension in pregnancy, and I am really delighted to talk to you today about this topic. I have no commercial conflicts of interest. I was the principal investigator of the CHIPS trial, which I will include in my talk. And I used to watch and weight blood pressure, and I do no longer based on the results of CHIPS. So that's my disclosure. So we talk a lot about measurement of blood pressure in pregnancy. We accept that it is a critical part of antenatal care. And my main points today are going to address control of blood pressure. If we're measuring it and we find that it is abnormal, then we need to get on with treating it. And I do think that we need to empower women not only to advocate for themselves when they have symptoms, but also to have high blood pressure literacy, knowing what their blood pressure should be in pregnancy and beyond for a healthy pregnancy, a healthy baby, and a healthy life. So we accept that pregnancy hypertension is associated with elevated maternal and perinatal risk, and we cannot predict at presentation with hypertension who's at greatest risk of those complications. It's accepted that treatment of maternal hypertension decreases severe hypertension, but there is historical concern that the antihypertensive therapy may impair growth. So I'm going to talk about that. CHIPS and other trials have shown that treating pregnancy hypertension is better for the mother without increasing risk to the baby. There's still no clear drug to use, which I want to be a positive message in that there are many choices. And while the importance of severe hypertension has been questioned, it is a surrogate for adverse perinatal and maternal outcomes, a pathway to complications similar to preeclampsia, but independent of it. And so the consensus is that it should be treated and promptly with antihypertensive therapy. So let me try to convince you of the details behind these points. So let's talk about the history. So antihypertensive therapy for non-severe hypertension has been hampered by a concern that this will impair fetal growth. And this meta-regression analysis of randomized controlled trials of drug versus treatment or drug versus drug supported concerns that lowering blood pressure may increase problems with uteroplacental perfusion, impair growth, and increase the chance that the baby would be born unwell and in the short and long term. So here on the x-axis, we see the difference in mean arterial pressure, and we see that the greater the antihypertensive induced fall in mean arterial pressure, the higher the incidence of small for gestational age infants and lower birth weight, which is that analysis is not shown on this graph. And therefore, a reluctance to treat with antihypertensive therapy is based on uncertainty about two important things. One, the importance of severe hypertension as an outcome worthy of avoidance, as opposed to something that we should watch for, and when it appears, treat it, and concern that treatment may impair fetal growth. So let me address these 2 points. So first, we always look to Cochrane reviews as high quality, reliable syntheses of information. And the message from Cochrane has changed. So in 2014, it was, quote, "It remains unclear whether antihypertensive drug therapy for mild to moderate hypertension during pregnancy is worthwhile." And then in 2018, it was, we had moved on. So despite more trials, we had no more that informed the severe hypertension outcome, but the message was, quote, "Implications for practice now reflect the benefits of avoiding hypertensive crises and use of additional antihypertensives." So there are 5 guidelines that are now advocating tight control, normalization of blood pressure in pregnancy basing their recommendations on the CHIPS trial. And I've just shown you the logo here. And this is a systematic review that we did of international clinical practice guidelines that sums up the recommendations of all of the guidelines. But we see here that Canada, the International Society, New Zealand, the UK, and now the WHO are recommending that women be offered antihypertensive therapy. So just briefly, let's review the findings of the CHIPS trial to illustrate our points. So there were just under 1,000 women with non-severe chronic or gestational hypertension recruited to the trial up to 33 weeks, because we felt that if antihypertensive therapy were to have an effect on fetal growth and therefore outcome, you would probably have to do it for a period of time, so days to weeks rather than hours to days. Most of the women, so 3/4, had chronic hypertension, and about 1/4 had gestational hypertension. The women were recruited at an average of 24 weeks and treated for 12 weeks. Less tight control aiming for a target of 100 versus tight control aiming for a target of 85 resulted in a difference in blood pressure of about 5 millimeters of mercury, which was what we were aiming for. You always have to aim for something bigger than what you hope to achieve in the end. And in the end, there was no difference in our primary perinatal outcome, which was pregnancy loss or high-level neonatal care for more than 48 hours, a measure of sick babies, babies who are separated from their mother, and babies who consume a lot of resources for the health system. So we see 31.4% versus 30.7%. So there wasn't any evidence at all that minimizing antihypertensive therapy what would be beneficial to the baby. However, the secondary maternal outcome, which was serious maternal complications, although not, sorry, my mouse is very sensitive, I apologize. While it was not significant, there were 3.7% serious maternal complications in the higher blood pressure control group and 2% in the lower. And the majority of these, and I think this is really important to note, were blood transfusions. And this isn't specific to the CHIPS trial. This is actually a theme in pregnancy trials in general. And there were no important subgroups for which the treatment effect was different. Importantly, we couldn't predict at presentation with hypertension which women were going to run into trouble, or which babies were going to run into trouble and which ones weren't. But there were some very important secondary outcomes that inform our thinking about antihypertensive therapy. The first is that tight control, so using antihypertensive therapy, produced a significant improvement in the incidence of severe maternal hypertension. So less tight control, 41% versus 28%. If we ran blood pressure higher, more women developed platelet count under 100. More women developed elevated liver enzymes with symptoms, and there were no differences in the baby outcomes. So birth weight under the 10th centile, 16 versus 19.8, or preterm birth, 36% versus 32%. And I'm going to come back to this point because there's a real focus in the literature on the birth weight outcome without attending to the preterm birth outcome. And I just want to point out that the economic analysis, so the costs associated with care also moved in the direction of the clinical. So less tight control appeared to be more expensive. We also followed up the babies because we wanted to know, to test the hypothesis that tight blood pressure control might result in antenatal undernutrition and reduced birth weight, and then be followed by accelerated postnatal catch-up growth as evidence of developmental program. And we know that catch-up growth may be detrimental to cardiovascular risk in the long term. And so this is a bit akin like being stuck in a traffic jam. And then when you get through the bottleneck, you then speed up. So growth is accelerated. Our primary interest was in anthropomorphic measurements at 12 plus or minus 2 months corrected post-gestational age. And we had 683 eligible babies because, of course, this was an optional add-on study to CHIPS. So 59 of our 94 centers participated. So here we see the median and interquartile range here in the box, and then the credible interval here for less tight control shown in black and tight control shown in red at 12 months. And you can see there was no significant difference in the change in Z-score for weight. So the rate of growth after birth. And then we had parental measurements done at 1 year, 2 year, and beyond. And you can see here that the boxes are looking very similar as we go on. So we had no evidence that there was any difference in postnatal growth. Now, I mentioned this, that there's a focus on the non-significant trend towards a 3.7% decrease in birth weight under the 10th centile in less tight versus tight control, but no attention paid to the non-significant increase of 4.1% in preterm birth. And the tension between the two, if the two of them balanced out, this might explain why we saw a complete lack of any clinically important difference in our primary perinatal outcome. And so one of our co-investigators asked whether gestational age at randomization should be considered when starting treatment. So could there be a point in gestation at which it might be better to minimize use of antihypertensives, and then maybe another point where if hypertension started then, it would be better to use antihypertensives? So the short answer to that question is no, but let me take you through the details. So this was a secondary analysis of CHIPS trial data published in Hypertension, and we looked at gestational age at randomization. So here we see from 14 to 34 weeks when we randomized women. On the y-axis, we see the odds ratio of less tight versus tight. And this is the horizontal line here is an odds ratio of 1. So everything that's completely below the line means less tight control, reduce the outcome, and anything above the line means that it increased the outcome. So you can see here that in up to about 24 weeks, if you minimize use of antihypertensive therapy, there are fewer babies ultimately born below the 10th centile. However, if you do that, you see that there are significantly more babies who are born preterm. And these effects, these contrary effects, seem to balance themselves out in that less tight versus tight control produce no significant overall difference in babies who die or babies who are sick and end up needing prolonged care. And this is regardless of when you initiate your blood pressure control strategy. So what about the mother? Well, if we take exactly the same approach, these are the same graphs I showed you for the baby. We see here that practicing less tight versus tight control all the way up to 30 weeks results in significantly more severe hypertension. The preeclampsia graph looks similar, however, the results aren't significant. And what we can see is that serious maternal complications are not different, although we're coming perilously close to less tight versus tight control, increasing risk when you practice it in the 3rd trimester. So we've talked about the birth weight issue, the focus on birth weight under the 10th centile without also focusing on preterm birth. But what about severe hypertension as an outcome that's important in and of itself, like preeclampsia, something we wish to avoid, not something we just wish to diagnose and treat? So Tom Easterling wrote in 2016, quote, recommendations to manage blood pressure expectantly, just watching it at under 160 over 110, and then saying it's an emergency when you hit 160 over 110, seem logically inconsistent, especially when a medical emergency can be prevented. So let's talk a bit about this. So we use logistic regression to examine whether severe hypertension is associated with more adverse maternal and perinatal outcomes. We, of course, adjusted for our blood pressure control and other things that are important prognostically, like maternal age and other baseline comorbidities. But importantly, we also adjusted for preeclampsia as an accepted surrogate for adverse outcome. We looked at preeclampsia in one of 2 ways. Here, I want to show you the baby outcomes. So we have our odds ratio and 95% confidence interval for the outcome. Here, the CHIPS primary outcome of pregnancy loss or high-level neonatal care. And what we can see here is that severe hypertension significantly increases the risk of that adverse perinatal outcome, and it does so even if you adjust for associated preeclampsia. And then the converse is true, is that preeclampsia increases the risk of the outcome. And you can see here it's fairly similar, even if you adjust for severe hypertension. So each of these outcomes is an important surrogate in and of itself. The results are very similar when we look at birth weight less than the 10th centile, and you can see here the significant p-values highlighted. And the results are very similar for the mother. We only had 28 secondary outcomes, and if you recall, most of those were blood transfusions. Severe hypertension significantly increased their risk, but once we adjusted for preeclampsia, it was no longer significant. And of course, preeclampsia significantly increased maternal complications as well. And very similar results were seen when we looked at birth weight under 34 weeks presented here, and birth at under 37 weeks, which I haven't shown in the slide. And so therefore, severe hypertension is not just a bigger blood pressure. And I couldn't resist showing a picture of one of my Newfoundland dogs. So it's a bigger blood pressure, but it is also a bigger problem. Now, which antihypertensive therapy to use? Hopefully, I've convinced you that we should be thinking about that when we find hypertension. Well, initial therapy should be with monotherapy from first-line drugs based on randomized controlled trials, most of them small. So, and internationally, there's consensus that the first-line drug should be oral labetalol, oral methyl-dopa, or oral nifedipine. But there are other choices, and it's more important to choose something and use it than to say, well, I don't have one of these three, so therefore I cannot treat. The choice of agent should be based on the characteristics of the patient. So for example, severe asthma would make oral labetalol a less appropriate choice, and contraindications to any one particular drug, as well as physician and patient preference. And Hypertension Canada recommends that additional antihypertensives be used if target levels are not achieved with standard dose monotherapy. So moving away from this traditional approach where we maximize the dose of one medication before we go to the other. That's not the approach we use outside of pregnancy. We're looking for synergy of effect, and we're looking for to work in the dose range where we see the majority of the antihypertensive effect. And so I just wanted to put up here a table that we've put together, an approach that sort of summarizes the starting doses of our medications and how to titrate and combine. Like this is a component of guidelines that we haven't developed as well. So here, if we start with the drugs and we have low doses, standard doses of these drugs, we proceed to medium doses of the same medication that we used in a low dose. But if that doesn't achieve our blood pressure control, then we're better to move to adding a low dose of a second drug, and then rather than moving to a high dose of the same drug, which we recommend is reserved until we're on 3 medications at low to medium dose. So just briefly to summarize the points about severe hypertension, 1, it matters, and CHIPS emphasizes the importance, and so does the Cochrane review, that all blood pressure at 160 over 110 must be treated as an urgency. But we don't, it can be lowered over hours. It doesn't need to be lowered over minutes, and that gives us the best opportunity to have benefits without risks. And that oral agents have advantages. And the nifedipine, the labetalol, and the methyl-dopa that we use for non-severe hypertension can also be used very successfully in at least 80% of our patients based on the Genuity oral antihypertensive trial, in which women with severe hypertension in India were very successfully treated for their severe hypertension, and actually in an environment where they used very little magnesium. So just to sum up, the main points that I hope to have covered and convinced you of is that pregnancy hypertension is associated with elevated risk. I think we all started from that point. That's why we're all here today. that we cannot predict at presentation who's at greatest risk, that treatment of maternal hypertension decreases severe hypertension, but the historical concern that antihypertensives may impair fetal growth is not something we should be focusing on. CHIPS and other trials have shown that treating pregnancy hypertension is better for the mother without increasing risk to the baby. And while the importance of severe hypertension has been questioned, I hope now we're in agreement that it's a surrogate for adverse outcomes. We should try to avoid it, and certainly if we haven't been able to avoid it and it occurs, that we should treat it and treat it promptly. So I just want to thank you very much as the president of ISSHP for your attention on what I feel is such an important area of maternity care and care for women. And I just really hope that that we can carry on with days like this every year in the future. Please feel free to email me if there's anything I can clarify about the talk or anything related to pregnancy hypertension. I'm always delighted to hear from those who are interested, and thank you so much for your attention today.
Thank you very much, Prof. Laura Mji, for an excellent presentation and shining the light on the impact of antihypertensive medication, and not only talking about preeclampsia, but severe hypertension as well. We really appreciate your insights, and I would like you, the participants who have questions or the speakers that have questions, to please post them in the chat. We will not answer, Prof. Mji will not answer the questions now, but we will move to the next speaker and deal with all the questions during the question and answer session. Thank you, Prof. I will now move to introduce our next speaker, who is actually going to be giving us our keynote address. So our next speaker is Dr. Oshri Tumshab, who is a scientist at the Department of Sexual and Reproductive Health and Research at the World Health Organization head office in Switzerland. So Prof. Oshri is in collaboration with the country, regional, and global partners, and uses quantitative and qualitative research as well as innovative approach to research the quality, again underlining the quality of care for maternal and newborn health, including maternal morbidity and safe abortion in low and middle income countries. She led the work on the World Health Organization recommendations on antenatal care for positive pregnancy experience, released in November 2016. And she currently leads the research, evidence synthesis, and implementation portfolio on antenatal care for the department that she is working in. Furthermore, she plays a key role in the World Health Organization initiated Global Network on Quality of Care, managing the research, the evidence thesis, and measurement portfolio on experience of care, including the mistreatment of women and labor companionships. Her work includes various initiatives, some of them including program reporting standards for sexual, reproductive, maternal, and newborn and child, as well as adolescent health, and the application of the ICD-10 cause to death during the perinatal period. She completed her degree at Istanbul School of Medicine, and she has a Master of Public Health degree as well as a PhD obtained from Johns Hopkins Bloomberg School of Public Health, and she's also been a postdoctoral fellow at Yale School of Medicine. Prof, thank you for accepting the invitation and joining us for the conference. The floor is yours.
Thank you very much. It is a pleasure to be here, and I'm going to be sharing my screen to show you my slides. Thank you very much, and for the invitation. It's wonderful to be here in this inaugural event and to be speaking after we were brought to the sort of the experience of what does it mean to have this disease that we've been talking about and that we are here to talk about from Ashley. And then my colleague Laura did a fantastic presentation on the latest research and evidence in terms of how do we manage hypertension and preeclampsia during pregnancy and childbirth, and the whole day is going to be honing in on this and focusing in on this. And now in my presentation, I would like to take us to the sort of the focus title of this year's conference, which is the quality of care. And I would like to bring us to the issues around quality of care, which will be very important to think about when we are thinking about management of preeclampsia, eclampsia, and hypertensive disorders of pregnancy as well. So just to briefly to take us to the sort of globally where we are and what we are looking at, I just want to show this trends in terms of maternal mortality ratio reduction, which is an indicator we use to measure progress globally. And it's the number of maternal deaths per 100,000 live births. And as you can see, there has been a decrease in MMR since 1990s globally, which is a very positive progress. However, if we aim to reach the Sustainable Development Goals, which we set out for us in 2030, then we need to accelerate this progress. As you see, the orange line is where we would like to get to at the end of 2030. And if we continue with the current rate of progress that we are showing now, the blue line is how we're going to be missing the target. And this is a global sort of outlook, and there are large discrepancies in this progress if you think about across regions and countries. So what does it look like? This is a snapshot from 2017. And as you can see, the maternal mortality burden heavily lies in certain parts of the globe like Africa and certain parts of Asia and Latin America. And again, I would like to caution us to think about differences in terms of certain populations of women or certain areas within or sub-regions within countries, so that when we look at these numbers, like the global estimates, we should be cautious that these might be masking underlying inequities across sub-regions and populations within the same country. And if you think about improving maternal health, it is not an easy task. So we're going to be honing in on really the hypertensive disorders of pregnancy, preeclampsia, eclampsia during this day. And as many of you know, there are other causes of maternal mortality and morbidity, like the prevention of postpartum hemorrhage, infections, sepsis, and others. So we need to, and also the increasing numbers that we see in non-communicable disease in terms of other NCDs that we are seeing, that we need to really think about holistically when we are looking at how to manage pregnancy and childbirth. And I just wanted to just put these strategic objectives of ending preventable maternal mortality, this effort. And these are 5 objectives. And just to show you, there are so many things that we need to think about when we are thinking about improving maternal health. We need to think about inequities in access and quality of sexual, reproductive, maternal, and newborn health care. We need to ensure universal health coverage for comprehensive care. How do we address, like I was mentioning, all causes of maternal mortality and morbidity and related disabilities? And we need to strengthen the systems that are responding to the needs and priorities of women, girls, and communities and healthcare providers. And how do we ensure accountability to improve quality of care and equity? And I keep saying quality of care because quality of care does matter. And that's what we've been seeing with the research as we were finishing the MDGs coming to 2015 and moving beyond 2015. We've been seeing a lot of increase globally, which is a positive thing, in terms of facility-based childbirth. Women were coming to the facilities and they were receiving their care from the facilities, but we were not really seeing the sort of related reduction in proportions of avoidable maternal and perinatal morbidity and mortality. So there, the major roadblock that we are sort of identifying is how do we improve the quality of care? And also with the research that we've been seeing in terms of the results, that just the coverage of essential interventions is not sufficient. It's very important, it's required, but it's not sufficient to go where we want to go. And also another thing that was emerging from the work in terms of like, this was the first review that looked at facilitators and barriers to childbirth in facilities in low and middle income countries. And one of the things the issues that was emerging was disrespect and abuse and mistreatment of women. So there's this complex interplay of experiences and lack of support that impact women's childbirth experiences and outcomes, and how and their use of the services for the current pregnancy or the later ones. And this is, I want to highlight this because when we looked at the evidence for mistreatment of women based on this, it was a mixed method systematic review looking at all the evidence globally. We found the experience of mistreatment not only in low and middle income country settings, but also in high income country settings. So this is an issue that was affecting women everywhere around the world. And then we said, okay, now we need to, as WHO and also many of our UN and otherwise partners, how do we go ahead with moving forward and moving the agenda faster in terms of improving quality of care? And also, it was in the within the aspect of efforts to achieve universal health coverage. So this is a very sort of opportune time to really put the highlight on quality of care. And this was the vision that we set out to do in terms of ensuring every mother and newborn receives quality care throughout pregnancy, childbirth, and postnatal periods. But there, we need some kind of thinking in terms of what do we mean by quality of care? And yes, you can define it, and we did define it, but also conceptually, what are we talking about when we say quality of care? Because then it will guide the way we would be measuring it, we would be designing interventions for it, we would look at accountability. And this is the framework that's built on many years and decades, and also many of collaborators and partners and research work, that this is the one that we put out for our work and to guide us. And here, quality is, as you see, situated within the health systems. Quality doesn't happen in a vacuum. Quality doesn't happen just when we are able to provide one intervention over the other. Quality really requires all the building blocks of the health systems to be able to sort of happen. And when we say quality of care within this health systems approach, we identified 8 domains that we should be thinking about when we are thinking about the domains of or components of quality of care. And one part on the left, you see provision of care, is where we're talking about evidence-based practices for routine care and management of complications. And this is a very important piece. And as my colleague Laura was mentioning, we need to follow the evidence, because as new evidence builds, the direction of our recommendations and the direction or the practices might need to be changed. So this is a very important area where we need to make sure that we are getting it right. The second one is on actionable information systems, because we need to be able to be agile in terms of responding to what's happening as we are looking at the data, as we are understanding how how the women are receiving care, what's happening in the system. So this is another important component. And also health systems are at different levels. Even within one facility, you can consider referral, but also from community, primary healthcare, secondary and tertiary, how do we ensure that we are allowing functional referral systems as a component of quality? And the one on the right side, the experience of care, was the one when we were first, the evidence was emerging, was the one where it was more sort of different, if you will, or for WHO, as we were focusing more on clinical interventions, something that we had to understand better, where the experience of care is as important as provision of care when we are thinking about quality of care. It's the woman at the center of the care. So it's about effective communication, about respect and dignity, and about providing the support that's required throughout the continuum of care. And of course, when we talk about person in the center, it's also the healthcare worker in the center of the system. How do we ensure that we have competent, motivated human resources who are able to provide good quality care? And again, if you look at the latest evidence, if 1 in 5 health facilities do not have the water that's required in any health facility, then how can we talk about quality when we are talking about facilities with no functioning toilets? So these are all important components of quality that we set out to say, okay, this is how we are conceptualizing quality, which led us to work on the WHO standards for improving quality in health facilities, where we, each of the domains that I mentioned would have a statement, a standard, and then quality statements and quality measures that helps us to define what is required in order to achieve quality of care. And I just want to give one example, especially as it refers to preeclampsia and eclampsia. And the standard 1 is about receiving routine evidence-based care and management of complications based on the recommendations, and the 1.2 is on preeclampsia and eclampsia. And I just put out the specific measures of input, output, process, and outcome that that focuses on preeclampsia and eclampsia. But again, like I mentioned, for any of these management of routine practices and also management of complications, there are certain standards and certain things as part of quality that we need to think about. Communication with women and their families is effective and in response to their needs and preferences. This is part of quality care if you're thinking of really sort of all the components of quality. Women and newborns receive care with respect and dignity, and every woman and her family are provided with emotional support that is sensitive to their needs and strengthens their own capabilities. And this approach and this framework actually guided our way through the continuum of care. So this was in 2016. Then in 2018, using the same framework, a standards document for improving quality of care for children and young adolescents were launched. And then more recently in 2020, the quality of care for small and sick newborns in health facilities was developed and launched, so that we are following the same understanding of quality as we are thinking across the continuum of care. What does it mean for WHO recommendations? These are a couple of highlights that I'd like to leave with you today. The first one, and this was actually, usually WHO guidelines have titles like reducing postpartum hemorrhage, reducing this morbidity, or reducing that mortality. And this was a way for us to think again in terms of how we are thinking about, for example, antenatal care, which is a health system platform that so many different interventions of screening, treatment, and support can happen throughout a woman's pregnancy. And in so many places, this might be the first time that a woman is coming into the health system. So how do we really have a holistic and comprehensive and woman-centered approach to the way we are developing our recommendations? And here, the whole concept of positive pregnancy experience came from systematic review, looking at what matters to women. And we followed this from antenatal care to intrapartum care and to postnatal care, which will be forthcoming in later this year, again with the same idea of what does it mean, sort of how do we ensure that we are responding to the needs of the woman as well when we are thinking about designing a health system and designing or thinking about recommendations. And I want to highlight just as an example here on the intrapartum care, where this is kind of with the woman in the center, all the different components of care that are highlighted in this guideline of 56 recommendations, which starts with first three, the experience of care components of respectful care and companion of choice during labor and childbirth, and also effective communication, besides all the other clinical interventions and also interventions where we say you do not need to do this. So it's very important to ensure that all the interventions that we are recommending or that we are providing care are actually needed and evidence-based, and that that has a really good reason behind them, and we are following the evidence. So, and here, as I mentioned again, it's important to think about the birth environment as well. It's important to think about, in terms of communication, how do we do informed consent processes throughout pregnancy and childbirth as well, to make sure that women are aware. We were hearing from Ashley in terms of how women did not realize certain things because they were not provided the information during antenatal care period, and then when it was during intrapartum and when birth was happening, maybe it was way too late. We should have thought about it, you know, during antenatal. And how do we ensure these things are happening appropriately? And again, how do we ensure that we have the appropriate mentoring and support to help health workers and empower them to provide better quality care? Very recently, we launched the WHO Labor Care Guide. It's a tool that aims to support good quality, evidence-based, and respectful care during labor and childbirth. So I just wanted to put it here for colleagues out there who are thinking of how do we apply certain measures in clinical practice as another tool that would actually help us do that in terms of good quality care. And again, evidence changes as we see new trials like CHIPS trials and others, and then we synthesize the evidence and then we look what it tells us. So to be able to ensure that we are doing it in a more agile way at WHO, we started using a living guideline approach where, for example, the guideline that I'm showing here, the original prevention and treatment of preeclampsia and eclampsia guideline, which was launched in 2011, we have been, instead of sort of waiting and updating the whole guideline, we have started looking at all the recommendations in the guideline and across maternal and perinatal health recommendations in WHO to see where new evidence has started building up. A new trial has been sort of released, and then we might need to relook at the evidence synthesis and update the Cochrane review, and then see if our guideline needs updating. So here, I suggest to follow the website on the recommendations, where you see all the updates to the recommendations. Three main ones for 6 recommendations in 2018, and we had additional ones in 2020 to see what's the latest evidence and what's the latest guidance from WHO on the prevention and treatment of preeclampsia and eclampsia, among the other maternal health and the perinatal health recommendations as well. And the other thing that I want to highlight here is we need to think about quality of care also as sort of within the health systems, as I was mentioning. How do we do it as a function of health system where we have quality improvement as part and parcel of it? So this is a broad partnership, quality of care network, between UN agencies and also many of the partners that I just highlighted here across 11 countries and counting, to work to ensure that this vision of quality is actually realized in countries. And this is a network that's going to continue its work until 2022. More recently, we launched the progress report just a week ago. And I also wanted to highlight the importance of integration of stakeholders and community engagement in any quality of care initiative for maternal, newborn, and childbirth. And here we have a toolkit that actually looks at how do we do community engagement properly? How do we really hear the communities who have been going through the health system, who have been going through these complications, so that we improve the systems and provide the quality care that they deserve and that they have a right to. The other thing that I've been mentioning throughout is the importance of ensuring the sort of the working environments for healthcare workers as well. And we've been using the term caring for carers. And especially if you think about pregnancy and childbirth, many of the carers are women themselves, and that they are facing the societal sort of be it gender discrimination, be it other sort of negative impact of being a woman in any society that we are living through. And how do we ensure that, for example, they are also not being disrespected, and they are also having the right to be able to express themselves and have the supplies and the environment to be able to provide good quality care. So I think this is a very important component that we should be thinking about, and that we are thinking about as we are moving towards improving quality of care for women and their communities. And I just want to sort of coming to a closure, we are at a very critical time for quality of care. These are just recent, sort of over the last couple of years, three sort of large reports that came out that actually highlights the importance of quality health services, importance of better health outcomes through improvement in quality, building quality mechanisms into the foundations of health systems, and how do we focus on person-centered care. And we cannot do it alone. We need all hands on deck. And this is just an example of how healthcare professional associations have come around to support the quality of care framework and the work that we've been doing in low and middle income countries to work together and to join our sort of join forces and to really try to walk together. And again, and I heard it in before my presentation as well, we cannot do it alone, and all the advocacy and grassroots movements are so much important and necessary, and is going to make or break how we actually sort of in health systems and in societies improve quality of care. So these are just some recent examples, for example, with the Respectful Maternity Care Charter and What Women Want campaign, where more than 1.1 million women actually spoke up about what they want from the health system. And as you can see, the first one is respectful and dignified care. So these are things that, these are the movements, and these are things that we should be hearing and getting sort of together to make sure that we are moving towards the vision and the objectives, and not only 2030, but beyond, and not only pregnancy and childbirth and hypertension, but beyond. So I think these are really important lessons and messages that we need to be hearing and partnering with. So with that, I would like to thank you again for giving me this opportunity to share this work with you, and opportunity to hear from you. And I look forward to any questions, and this is my email. Please feel free to reach out, and thank you.
Very much, Prof. Özge Tulcap, for an excellent presentation, for taking us through the World Health Organization guidelines in a way that we are able to understand, and most importantly, highlighting an important fact of caring for carers. I mean, I believe the participants and colleagues here can agree with me that in Africa, those people that are caring for our mothers and children, a large percentage of them, just like anywhere else in the world, is women, and we cannot achieve the optimal quality of care by only looking at the mothers who are suffering, but we also need to look at the carers who are themselves can be mothers and are also affected by the work. And also another point, very interesting, that is mentioned is that a lot of women mentioned by the World Health Organization articles that working conditions, not only for the carers, but for women in general, need to be taken into consideration when thinking of ways to optimize quality care for women who are at high risk or who have preeclampsia or other hypertensive disorders in pregnancy. So with that, I would really like to thank you, Prof, for your time. And before we open the panel discussion and question and answer session, I would like to encourage the participants who are here on Zoom to please post your questions, any thoughts on these themes in the chat, and we will have the speakers in the panel, speakers who form part of the panel, answer your questions. And if you would also like to be unmuted and share your thoughts with us, you can raise up your hand and we'll unmute you so you can share your thoughts. So we have two ways to do it. You can post questions and thoughts in the chat. Alternatively, if you want to share a thought or add to something that has been discussed by the speakers, you can raise up your hand and be able to discuss, to join the panel discussion with your mic unmuted. But please remember that if you are unmuted, as soon as you're finished with your contribution, you need to mute yourself again. And those who are joining us from Facebook, please also just post it on the comment section in Facebook, or share your thoughts there, and we will try and share them with the panel here, working together with my team. And also, if you have questions, you are more than welcome to post them there in the comment section on Facebook. And I'll also like to encourage those who are here in Zoom to please look at the chat. There's a lot of information that is very useful. It's been posted in the chat, links to various platforms, including the World Health Organizations that you can use. Please make use of these resources. Without any further waste of time, I'm going to ask our speakers that are here to please prepare yourself to kickstart the panel discussion. And with this panel discussion, I would like to ask to kickstart it with the questions that were asked for Prof. Laura and Prof. Oski. So if they could first try and answer those questions that arise from their presentation, and then after that, we will move to the multi-professional collaboration to reduce the adverse outcomes of HDP. So Prof. Laura and Prof. Oski, please, I'm going to start by reading out the question for everyone that was in the chat. So this question is with regards to the use of antihypertensive medication. We know very well that populations of African ancestry respond differently to some classes of antihypertensive medication, independent of pregnancy or preeclampsia. So what is being asked here is whether we will also be if pregnant women will also be expected to respond differently to certain classes of antihypertensive medication. So Prof. Laura, if you could please unmute yourself and give us your thoughts on this question, that would be great. Thank you.
Oh, thank you. This is an excellent question. We know when we think about antihypertensive therapy outside pregnancy that different drugs theoretically and practically are better in certain ethnic groups. And with women of African descent, we would anticipate low renin hypertension. And so drugs like methyl-dopa and beta blockers may be poorer choices than calcium channel blockers. I think so. While that is true outside post-pregnancy and probably true in pregnancy. Recent work suggests that still the majority of individuals outside pregnancy respond to the drugs we don't think are ideal for them, and that's certainly true in pregnancy. So we can anticipate that more than 80% of women in pregnancy, regardless of their ethnicity, will respond to a drug like labetalol. And I guess what I would really like to emphasize is the important thing is to use something, and that if we get too stuck in on we have to have this drug or we have to have this drug for this type of woman, and if we don't have the drug then we can't treat, I think is just gives us another barrier to getting care to the individuals who could benefit from it.
Thank you, Flora. In addition to that question, they also mentioned that about a huge interest in this question, and also add the fact that some medication like nifedipine is available orally. And Dr. Emmanuel Schofreno, if you are here, would you also like to share your thoughts on this topic?
Thank you very much, but I didn't, if you can help me again with the particular question that you want me to address.
Yes, it's with regards to the antihypertensive medication in pregnancy with specific reference to women of African descent because of the known differences in response to various classes of antihypertensive medication. And in addition to that bigger question, someone also highlighted the issue of nifedipine being available orally, and if there's anything that you could add to that. But overall, it's about the response to the different classes of antihypertensive medication and which ones will be best, maybe, when working with women of African ancestry.
Thank you very much for the question. I must say that where I work, which is the Greater Accra Regional Hospital, is a large regional referral center. The choices we have are relatively few. We normally have choices between labetalol and aldomet. And then for acute control of hypertension, we usually apply injection labetalol or injection hydralazine. And we find these to be very extremely helpful. However, the injection forms are not always suitable for the frontline staffs because you have to take specific dosages. You have to be careful to monitor the patients to make sure that you don't suffer or there is no complication of hypotension and so on and so forth. So we have over the years where I work used tablet a tablet form of nifedipine, which is a short-acting form and which we have found very effective. We don't have much experience comparing these medications where I work with the others from maybe other parts of the world to know who responds to which one better. But then we have found aldomet, oral aldomet, and then oral labetalol to be very useful to our clients. And then now we've added to the pack oral nifedipine plain tablets, which are also very helpful and especially helps to control blood pressure in acute situations, especially in the outpatient, in the rural communities where the midwife may want to administer something quickly and then refer the patient to the higher centers. Thank you very much. Over.
Thank you, Dr. Emmanuel, for sharing your thoughts on that. And I completely agree that in Africa, we don't have the luxury of choosing between different types of medication. Even generally in hypertension, we know very well the low renin phenotype in our populations, but we don't have those medicines to actually use for that type of hypertension. So that is a challenge that we are experiencing. And exactly. Yes. So the next question here is from the survivor, whom Prof. Laura indicated that she can clarify the answer in the question and answer session. Now, where she indicates that her baby was delivered at 34 weeks and have been on blood pressure medication since then. But now she wants to know how long will it take for her blood pressure to stabilize? Prof. Laura, if you can just clarify as you indicated in the chat for us, and then the other speakers can just chip in to add their thoughts. Thank you.
Yeah, thank you. I think it's very important to hear such stories and to have the opportunity to address the aftermath of preeclampsia for mothers and for babies. This is an area of care that I haven't seen anyone do this well anywhere in the world. So women with preeclampsia have hypertension and proteinuria and other abnormalities that can obviously take some time to resolve. And for some women, it's over hours to days, and others days to weeks, and some it can take a few months. But really, in general, by the time we reach 6 months after birth, we regard any residual elevation in blood pressure as reflecting chronic hypertension, as essential hypertension. Depends on the doctor who you see, but in maternity care we call it chronic hypertension. And we don't think that preeclampsia caused the chronic hypertension. Although there may be some ongoing ramifications from having a preeclampsia, but we think that the majority of that elevated blood pressure results from a tendency that was there before, and that underlying predisposition resulted in the preeclampsia during the pregnancy. So the pregnancy unmasked the predisposition to hypertension, and the elevated blood pressure has carried on. And what I would do is encourage you to view this as empowering you to have found that predisposition earlier in your life, and be literate about what your blood pressure number should be, and take your medication, and you can affect your long-term health. And this is this health in the long term is the message that's being advocated by the ISSHP and the Preeclampsia Foundation in the UK this year. And if you look at their website, there are there's a tool, is like My Health tool that's free of charge, and gives you little chart and tracking and some sort of practical advice about how to take charge of your health and really optimize it in the long term. So I really thank you for raising this important issue today.
Thank you, Prof. Just a last follow-up question on that regarding the long-term implications of this. This is a specific question from one of the participants saying, what is the probability of preeclampsia recurring in the subsequent pregnancies? Can this be prevented? And with this follow-up question, I would like to invite Dr. Salisu to maybe elaborate on this, because he will also be talking about it during his presentation. Dr. Salisu, please tell us what your thoughts on this. Thank you.
Yes, thank you very much. I think I had some of the presenters talking about it, but let me add my own perspective. In general, we expect about between 2 to 4 times the risk of recurrence after having one phase preeclampsia. But of course, we know that women, in terms of preeclampsia occurring, women are classified into 2 risk groups, those at high risk and those at low risk. So those at high risk, whenever they have any of the risk factor, one of the risk factor, they are generally, WHO right now has confirmed that these women can be placed on low dose aspirin from 75 milligram to 150 milligram, starting after 12 weeks of pregnancy until delivery. And that has shown to reduce the risk of preeclampsia occurring by up to 8%. And also women, many communities really don't know our calcium consumption, so we cannot generally say who has low calcium intake. But if there is evidence that a community has low calcium intake, then of course calcium supplementation can be taken also throughout pregnancy to also reduce the risk of preeclampsia. So of course it can be prevented, but not 100%, but 8% is very huge and has been found to be effective in many populations. Thank you very much.
Okay, thank you. Thank you, Dr. Ishaku. So one additional question, the participant would like to know, is there anything that they can do themselves to get their blood pressure back to normal after delivering? If it's not going down, what else is there anything that as an individual someone can do to lower their blood pressure? Because there seems to be an eagerness. People would like, after giving birth, they wish the blood pressure can just go back to normal, but as you've discussed, it's not something that can be easily achieved. So is there anything other than the medication that people can do?
Yes, so I think we're taking up quality in this discussion, and from my experience when I was practicing obstetric, we certainly have problems with the quality of medications that we use. Both the labetalol, nifedipine, and in some cases that we can use aldomate, they are very, very effective. They are very efficient when you use them in other settings. People don't complain about inefficiency. Blood pressure usually comes down. But in this part of the world, in Nigeria in particular, where I live, I know that issue with quality of medicine is very, very crucial. Sometimes you take drugs that are counterfeited, or they are substandard, or they don't even contain any active ingredient at all, and you don't know. But let's assume that you are taking real medication and your blood pressure is not going down. And I think I've had Laura also actually gave us a very good practical approach of taking care of that. You start with monotherapy, low dose, and then when you are not achieving result, you can maintain the low dose and add the second drug at also low to moderate dose until you go to third dose. I think that should work very well. But also, what women can do on lifestyle changes, what I can talk about then is try to make sure that the weight that we gain in pregnancy, we try to reduce our weight significantly and to minimize our sodium intake. So like no other salt in our food, and to do some exercise. And I think with those pharmacological intervention, in most cases, blood pressure should be able to come down.
Thank you, Doctor. And to just add to what has been advised in the chat to women who have questions about how to get their blood pressure to a normal level after delivery. It's not that delivery is the cure. Once you deliver, then the blood pressure will completely drop, will immediately drop. It's a process. So if people could just understand that it's a process and not that after giving birth, then you are cured, I think it will really help with that. Thank you, Isabella, for that comment in the chat. So we will now, together with the speakers, move to the theme on multi-professional collaboration to reduce the adverse outcomes of HDP. So I have interesting questions from the chat to discuss this, to kickstart the discussion. And I would like the speakers also, you can just raise your hand and unmute yourself to answer these questions. We would like to know, what do we do to increase the government as a role and investment, maybe from the government and other sponsors, in programs aimed at reducing the prevalence of eclampsia or pre-eclampsia? Is there any advice from based on your experience that you can give people who are just starting up with this kind of programs? How do you get the government to be involved? How do you get sponsorship to invest in your programs so you can achieve your goal? So I would like the speakers to please give their input on this. Maybe I can just start with Prof. Oski, who is at the World Health Organization. What would you encourage people to do to attract funding and get governments involved?
I think this conference and this panel that we are hosting and you have been leading is one of a very good example of getting not only the healthcare workers together, but also the women themselves and the families, and not starting with any of us, me or Laura or any, but starting with the actual lived experience of what it meant to go through this as a woman, as a person, I think is a very, very strong message to start with. So whichever way, be it a presentation, be it an evidence brief, any advocacy documentation, I think not losing the aspect of that it's not a disease we are dealing with, it's the woman, it's the families, it's the babies, that's at the core and center of it, I think is a very strong message to get support from government and from other partners and other stakeholders, donors, to keep this at the forefront of their interests. So I think this is something that I would highlight, and we try to do at WHO as well. So I'll stop here.
Prof, and following up onto that question, this specific question is with regards to prevention. What is currently being done? I'll ask specifically those who are the speakers who are giving care to women. We have this question of what is currently being done as part of primary preventive care for preeclampsia. How can women, what should women do to prevent or minimize the chances of having preeclampsia? Because there's uncertainty with regards to this. Whose responsibility is it? Is there preventive care or primary prevention? Does it solely lie with the antenatal care staff to educate pregnant women? Or who else should do what? So this is, the clarity is needed on whose role is it when it comes to primary preventative care. So I'm gonna again invite the speakers to please just chip in and give your thoughts on this. Whose responsibility is it to educate the women? Is it the antenatal care staff? Is it who? So if we can just discuss that, it will be great for the participants. Thank you.
So hello, I would like to make a point here.
Yes, Dr. Emmanuel, please share your thoughts.
Thank you so much. I would like to say that it is everybody or all of us our responsibility to play a role in the area of primary prevention. Having said that, I'm also sorry to say that in terms of primary prevention, we don't have much in terms of success in terms of primary prevention, because this is a condition that we currently, by the scientific knowledge, we are not very sure as to the exact cause. And so primary prevention will mean that we put in place interventions that the disease does not occur at all, but we don't know the cause. And so we only can determine, the best we can do will be to determine those who are at risk, use some kind of risk stratification, maybe depending on obesity, previous history of preeclampsia, and so on and so forth, and determine those who are at risk and use that risk approach and educate them on lifestyle choices, and also educate them on the use of maybe those who are in care, look at the possibility of giving them calcium if they are of that group of taking low calcium intake or using soluble aspirin. So really the choices are not much. However, in terms of education, in addition to the family planning nurses, we can also rely on public education. And then we can also rely on conferences like as we are doing now. We can also rely on the role of support groups like the support group that are emerging now in Ghana. We have the APEC Action for Preeclampsia group, and they have done a lot in educating the public. Indeed, the public need more education than we are doing now. We need to send out the message out there. We need to invade the social media with information on preeclampsia and what can be done, the little things that women can do. And then when women are pregnant, the fact that they have to book early within the antenatal system, because we still have situations where women who report to the antenatal clinic very late, sometimes after 20 weeks, to book for the first time with their blood pressures already high. So it is important for the message not to be left only at the antenatal clinic, but the message should reach the public within the public space. That is where the message should be. Thank you very much. Over.
Is there anyone anyone else who would like to add to this? Yes, Prof. Laura.
I wanted to, thank you. I wanted to, just to make a couple of points. I think that they relate to dealing with government as well as dealing with the public. It's I think because there are just so many things that we need to do, need to say, need to ask, that we should probably pick a focus at a particular time and try to really see if we can get traction with that particular message. And I think for example, the Preeclampsia Foundation has had as a focus for a very long time, empowerment, and they focused on women knowing the symptoms of preeclampsia and not allowing themselves to be brushed aside or dismissed, but saying, no, I know that having a headache or having this visual symptoms or having epigastric, I know this is important, and I am not going to allow myself to be dismissed, and I'm going to insist that somebody take my blood pressure. And I suppose it's a different approach with our different target populations, but I think that's why days like this and organizations like Ashley has started are so important in getting these messages across. And I think that if we're looking for support from above for particular programs, that it's really good to have a focus. We would like to do this thing. This is our simple message. It's not like, we know it's not simple, but to have a focus that we want to do this in order to achieve that. And we're going to do it over this period of time. And just to make people feel that what is a global overwhelming problem is manageable. Like we can break it down into pieces. And then finally, I would say that speaking about empowerment, that I think getting moving is something that's been kind of a more recent focus of conversation within the pregnancy hypertension community. We know that obesity is actually the risk factor that has the best evidence behind it for increasing the risk of preeclampsia, and it's very strongly related. And getting moving and having an active lifestyle, and then doing it while you're pregnant as well, prevents preeclampsia. And so it's I think it makes our message something that everyone can listen to and say, yeah, I could do that. I could do that. And I could do that with my partner. And well, while I'm at it, I could do that with my family as well. So thank you.
Thank you for that. I mean, from both the comments that you made, risk stratification is very important and involving almost everyone who is affected by this, families, friends, primarily healthcare services is the way. So we need all these multiple role players involved if we are to achieve what we would like to achieve. So thank you for that. Dr. Ishaku, your hand was up. You can give us your thoughts, your additional thoughts on this. And after that, we will move to the second point where Ashley would like to share something. So Ashley, if you can just prepare that after Dr. Ishaku, you give you share your thoughts on challenges in communicating HDBP to patients. Yes, please just get ready. After Dr. Ishaku, it will be your turn to speak. Dr. Ishaku, please, it's your turn.
Okay, thank you, Lebo. I have listened carefully to Laura and Emmanuel, and I think I agree with them 100%. But I just want to introduce another perspective that if we are really speaking of Africa, I think we also need to ensure that if our women want to take responsibility too, we need to ensure that a culture of preconception care is taken very serious, because people have taken about BMI, they've taken about women with chronic hypertension, women with pre-existing diabetes. If these women actually come for preconception care before they become pregnant, all these risk factors can be modified before they can embark in pregnancy. Women would women that are obese can be placed on a program that will enable them to reduce their body weight and a healthy one. Women with chronic hypertension can also be controlled Also, women with diabetes mellitus can also be controlled. And in that case, women will go into pregnancy with optimal health status, and that would improve the chance of not getting preeclampsia. In addition, because women have attended pre-conception care, when they also become pregnant, they are also likely going to register their pregnancy within the first trimester. In Nigeria, only 5% of women register their pregnancy in first trimester. And I'm talking about data from teaching hospital. It means when you go to primary care and secondary care, women don't come to hospital until some of them are 30 weeks. In fact, many of them during delivery, that is when they come to the facility for the first time. If we don't come to the hospital in the first trimester, all this intervention we're talking about, the low calcium aspirin, the calcium supplement will not be available to you because they have to be given as early as possible. So these are the two to add. One is encouraging that we start the culture of pre-conception care, and secondly, early trimester booking of pregnancy. Thank you very much.
Dr. Ishaku, you actually answered some of the questions that were in the chat, so I will not repeat the questions. I hope the participants also feel your discussion and your thoughts were enough. So as you've also indicated, what can be done, getting the message out there is one of the key components of achieving optimal care or quality care. And on that note, I will invite Ashley to share her thoughts on the challenges involved in getting that message out there where it must be heard. Ashley, over to you.
Thank you very much for that. So one of the challenges involved in communicating hypertensive disorders in pregnancy to patients and how to overcome these challenges. Well, our organization is patient-based, and what we've been experiencing as challenges is, number one, we've come to notice that in as much as we are concentrating on educating the women during antenatal clinics, probably we should approach it from a family unit. And this is because, we've realized that quite a number of the people who are making decisions in the maternal health and in the pregnancies of these particular women are the husbands. Yeah, and recently we even had a case whereby the husband refused to take this lady to a hospital that is specialized in treating hypertensive disorders of pregnancy, and took her to a different hospital and insisted that everything should be taking place in that particular hospital, which is near where they stay. So one of the challenges in or how to overcome this particular challenge is also to approach and sensitize the family as a unit and communicate about the dangers and how they can be able to know how they can be able to detect the symptoms early and how they can be able to get help. Because if they don't know about it, then probably the chances of the male, in this particular now the husband, to allow the women to get quality care is not available. The other thing is the social economic factor. One thing that is also quite a challenge is, especially in Africa, treating hypertension in pregnancy is very expensive. You can imagine that's like $15 of medication, and that's only one medication, I would say probably labetalol. Then you have scans, and you have all these other things that you also want to do to allow your pregnancy to be flawless. But now the women are being faced with the challenge of either providing food or using that particular money to get food or to buy medication. And how can we as patient-based organizations come in and really do a good advocacy approach to researchers also? Because I look forward to the day when we'll have a drug, a specific drug that can only cure this whole thing or help prevent, so that ladies won't be able to have a whole list of medication that they can be able to buy and then use all that money probably in buying medication, yet we can get like one source of treatment that can be able to help the women. The other challenge, as I conclude, is cultural and social beliefs. What we are facing here in Africa, a lot of people associate symptoms of hypertension in pregnancy to be either a cheating spouse or witchcraft, bad eye, and food. And these are the things that we are also tasked with when we are communicating about hypertensive disorders of pregnancy to women. So what we are doing as an organization here in Kenya, we are providing photos of how you can be able to look like, coupled with doctors' reviews on what can be done. This is not because your husband is cheating or because someone is doing something of witchcraft towards you. This is a medical condition, yeah? And because of this also, a lot of women are experiencing stigma, you know, from the fact that they're experiencing these symptoms of preeclampsia, of swelling, and they're being told now you don't want to exercise. That is why you're swelling and all these things. So these are some of the challenges that are involved in communicating hypertensive disorders of pregnancy to patients. Probably I can add one more comment, and that is to access of quality. And this goes hand in hand with information. I missed to tell a part of my story where when I went to the hospital, one of the hospitals, when I was going through placental abruption, I went to the clinic that is near where I stay. Yeah. And because I went to this particular, facility, there was no gynecologist on site. Yeah. But probably if I was not transferred to a major hospital, I should have gone to a hospital that has 24 hours obstetrics care, that has an anesthetist and everything. So these are the things that women also do not know about. And patient organizations around Africa should really communicate the urgencies of going to a proper hospital that has facility and 24-hour obstetrics care in case there's need for a cesarean section. Otherwise, when actually I was in that local hospital, the guard told my dad as he was entering into the hospital that ladies who come in bleeding the way I did never make it out. So I took that statement as a lot of ladies come into that hospital and probably lose their lives when something should have been done or could have been done, but they end up losing their lives in that particular facility. So it's very important for us as patient-centered organizations to really communicate the importance of those challenges that I have communicated about. Thank you.
The speakers for sharing your theoretical and practical advice on how to approach or work in a multi-professional collaboration to reduce the adverse outcomes of HDP. And I mean, Ashley, we cannot thank you enough for sharing your own personal stories, which even if someone has not suffered from HDP before, I mean, some of the behaviors, it's just unacceptable. And we hope that in future, women don't have to experience such negativity, stigma. They can be supported and have healthcare providers try their best to save these women's lives and possibly their babies. So with those comments, I'll just be concluding the panel discussion and really thanking everyone for sharing your thoughts and contributions. And those who didn't get a chance to talk in the panel discussion, do continue with posting your thoughts in the chats and we can just read them as we go. So now we will take a quick break and come back at 12:15. Yes, to have Dr. Emmanuel continue with his thoughts and sharing his expertise and experiences with us as we aim and work together to achieve quality healthcare for preeclampsia. So that's it. Thank you all. I'll see you again in 15 minutes after 12. back, everyone. I will now be introducing our second speaker, which is Dr. Emmanuel Schrofenel, who has been also giving input during the panel discussion. So Dr. Emmanuel will be talking on improving quality of care delivered in hospitals to improve HDP outcomes. So I'll give a brief introduction and then Dr. Emmanuel will take the stage. So this background, briefly, Dr. Emmanuel is a fellow of the West African College of Surgeons and a foundation fellow of Ghana College of Physicians and Surgeons. He is a consultant, obstetrician, and gynecologist at the Greater Accra Regional Hospital, where he's also currently the medical director and also the chair of the faculty of obstetrics and gynecology. Dr. Emmanuel, thank you very much again for availing yourself and sharing your thoughts with us throughout this campaign of creating awareness about hypertensive disorders in pregnancy. You may start with your presentation.
Okay, thank you very much. Let me first start by saying that I'm very happy and excited about this program, that for the first time, even we are coming together as a continent to talk about the issue of preeclampsia. The title of my topic, Improving Quality of Care Delivered to in the Hospitals to Improve Hypertensive Disease in Pregnancy Outcomes. And so this is going to be the outline of my presentation. I will talk about, first of all, an introduction and then the model of care that we employ in my institution, which is the Greater Accra Regional Hospital, one of the largest regional referral hospitals within the country. We'll talk about some statistics and outcomes, and then we'll conclude. By way of introduction, I would like to say that in their quest to have a baby and bring joy to their families, women face a number of risks, one of which is preeclampsia. The medical and socioeconomic burden of preeclampsia is huge, especially in our part of the world. For example, in Ghana, over the years, we have realized that mortality and morbidity from preeclampsia has been on the increase, especially in the major hospitals like the major referral hospitals, like my hospital, the Greater Accra Regional Hospital, the National Referral Center, and some other teaching hospitals. We have seen this trend. But for the first time, for a survey that was conducted in 2020, which results we discussed yesterday, it has come out that preeclampsia now is a leading cause of maternal mortality and also perinatal morbidity and mortality. And so this is very concerning. Recent scientific advances has also brought better understanding to the disease condition. And for what we know now, prevention is not feasible on a large scale. There are some interventions we can do to prevent the disease, but the only way out is to improve the quality of care that we offer to these women who report to our facilities. I will start about talking about a model. Ghana Health Service had a partnership with an international agency called Kibeli. And through the work that we did in my hospital, the Greater Accra Regional Hospital, we developed a model for improving clinical quality or quality of care that is offered to women like those who have hypertensive disease and the rest. As you can see in the middle bar, the first bar concerns the primary foundational issues that should be addressed. In the middle bar, that is where we targeted on the output. And the critical ones that I would like to speak about in this presentation include ability to carry out early detection and appropriate timely referrals of cases, because we realize that when you are in a referral center, unless the cases come to you in a better condition, you are not likely to make any impact. And so whatever systems you put in place should also promote at the peripheral level, should be able to promote early detection and appropriate timely interventions and timely referrals. Then I'll also speak about improved patient surveillance at the institution. I'll also talk about the importance of clinical protocols and guidelines, and then timely interventions and reduction of delay. I would like to focus my presentation on these 4 outputs. Thank you so much. So talking about early detection and appropriate and timely referrals, as I've already said, that most of the time the patients that we receive are not patients that primarily come to book in our institutions. They first book in a sub-district or in a district facility or in a cheap compound, where in our part of the world, and then as the pregnancy goes along and when the hypertension is detected, the patient is then transferred. So the question is, are the patients booking early? And then are the condition being detected early so they can be referred early for us to catch them early and optimize the care so that we can hope of having a better outcome. So some interventions that we have put in place in my hospital is the fact that it is important to present data that is generated to the people who are generating the data. And that is, so one of the things we introduced was quarterly conferences where data referrals that we receive from the peripheral institutions, we congregate the data involving the outcomes of these patients, we congregate this data and present back to them. And so during these presentation conferences, we let them know the gaps in the care or the gaps that we found. For example, you realize that sometimes the patient's blood pressure begin to rise, but usually the nurses at the periphery or the midwives at the periphery may not be sure of what is happening. So let's say the blood pressure begins to rise to 130/90. She booked with, let's say, 110/70. Her blood pressure begins to rise to 130/90, and then to 140/90, and then to 150/90, and nothing is being done until when the blood pressure becomes very severe, let's say 160/100 or over 110, then that the patient is referred. And so in such situation, we realize that we lose a lot of time in optimizing the patient's condition. And so through these conferences, we now realize that midwives at the district and the sub-district level now refer the patients in good time. Another important thing that I've actually referred to is a congregation or collection of relevant data for provision of feedback. Feedback is very important for the midwives and also community health nurses who refer cases to us. And then important thing also is training programs for medical officers and midwives from the lower level institutions. From time to time, what we do is that we invite midwives who work in the sub-district and then in the community hospitals to come to our center and see how these patients are cared for, how we make the diagnosis, how we monitor them, and so on and so forth. So sometimes they spend about a week to 2 weeks in our facilities before they go back. That way, when they see these patients, they know the possible outcomes and their attitude towards these patients change a lot. So this is also very important. And then finally, we also talk about creating and sharing referral guidelines. So we indicated at which point of the blood pressure that this patient needs to be referred, at which point in the urine protein that you think that you have to refer these patients, and so on and so forth. So we created guidelines and shared. We identified all our surrounding institutions who refer their cases to us on a regular basis and created common guidelines and shared with all of them. And so these are also some of the small group tutorials that we held. These are qualified doctors that are working the first box, qualified doctors that are working in district institutions and some district institutions. And they were brought to my institution where we gave them discussion tutorials for them to understand how some of these conditions can be managed, at least at the district level before the earlier interventions that should be done at the district level before they are referred to the higher centers. The picture here also shows some of the conferences that we have had. So one other area of intervention is surveillance of the patient through investment in appropriate monitoring equipment, tools, and establishment of high dependency units. It is important for us to know that even when the patient arrives in our doorsteps, and evidence have shown that the fact that the patient arrives at the higher institutions does not necessarily mean that the patient is going to have a good outcome. That does not necessarily mean that the outcome will be good. It is important to monitor the patient very closely, making sure that the appropriate tools are used. Next slide, please. So some of the interventions that we did to improve monitoring are as follows. First of all, we make sure that we have adequate blood pressure monitors. Even in the high dependency unit, we even installed electronic monitors so that the very sick ones or those who have their blood pressures that are very high, then we are sure that they can continuously monitor their blood pressures And then it becomes so easy when the midwives come or the doctor comes to check their blood pressure, they only activate the monitor and the blood pressure readings are there to guide the staffs in what they do. Because we have known that poor monitoring could also be an attitude of the staffs or could also be due to inadequate monitoring devices. And so one of the first interventions is to make sure that we have the devices, but also to simplify the work, simplify the monitoring process for the staff so that you can guarantee that the parameters are checked and then documented. Now, it is also important to know that when we talk about good outcome, when it comes to preeclampsia, we are not only talking about blood pressure machine, we are talking about the Dopplers, we are talking about CTG machines, we are even talking about ultrasound, because we are talking about a comprehensive care, a form of comprehensive care to these mothers. Some of them need an ultrasound care, so there must be an ultrasound in the labor ward. There must be CTGs in the labor ward so that they can be comprehensively monitored when they are in labor. So I spoke earlier on about the development of high dependency unit. Pre-eclamptic patients cannot be managed successfully or should not be managed, especially for those who are acutely ill, should not be managed in the general ward. These are practical issues. Should not be managed in the general ward because the attention of the staff may not be on all the patients and be well focused on the very sick ones. So one of the interventions that we did in my hospital is to create a high dependency unit where cases like severe preeclamptias are placed. And so with the high dependency unit, we also engender continuous electronic monitoring of the blood pressure in those cases where the blood pressure is really very high. There are times that we have blood pressures as high as 250 over 180. When you have such situation, you want to initially monitor the blood pressure very frequently as you give your acute medication to control the blood pressure. So you can see photos where a patient who is on electronic device is also receiving an ultrasound scan of the heart and then also of the abdomen to make sure that she's not in heart failure and so on and so forth. Thank you so much. Next slide. Another important area of intervention when managing preeclampsias is to make sure that we have standardized protocols. We cannot be in an institution where people will do things in different ways. It is important to ensure that we have standard protocols that are deployed within the institution where care is given. And one of the things that we did is not only standardize the protocol in our institution, but also standardize the protocol with the other institutions that refer their cases to us. So all the district hospitals and all the sub-district hospitals that are within our jurisdiction, we shared our protocols with them. And so you are sure that even when some medications will be administered at the beginning before they are even referred, these are medications and protocols that we know we will also use in our center. Now, the importance of protocols cannot be overemphasized. This is because protocols are known to standardize care and empower the young members of the clinical teams. Once we are all conversant with the protocols, any first-line staff, like a midwife, who receives severe preeclampsia at a particular hypertension, know what acute medication to use, know what drug to use, know the dosages, know the frequency, and so on and so forth, because that is the standard that has been used in the unit. Many randomized controlled trials have demonstrated improved outcomes when protocols are implemented into clinical care decision-making compared to when experts are allowed to use their own judgment. Evidence-based protocols were designed for each major particular clinical condition. For example, hypertensive diseases in pregnancy in our hospitals. We even developed protocol handbooks, and then these were shared and made available to any new entrants to the hospital, to the department. So when you come, we even share it with you either on WhatsApp or we give you the hard copy book so that you know the standard protocols as far as the management of a particular condition. And here we are talking about hypertensive disease are concerned. So these are evidences. So we develop midwives obstetric emergency triage protocol. And then we also develop a handbook for all clinical staffs of the department so that they know the standard way that particular conditions are managed. And then we even develop forum where protocols that are developed are discussed within the department so that everybody will be very conversant with the protocol. Again, we must know that mere development of the protocol and sharing may not be enough. We must have forum to discuss the protocol so that everybody will be on the same page when it comes to management of these particular conditions. And so just to summarize this first part of the presentation, severe preeclamptic women in my institution are first admitted to the high dependency unit for initial care. We established the appropriate monitoring protocols. Now, when it comes to monitoring, we established 2 monitoring protocols. The first one that we call the emergency monitoring protocol. In the emergency monitoring protocol, the patient has come freshly, is very unstable. The emergency monitoring protocols are then applied. In this category of cases, blood pressures usually are more than 200/120. And so we feel that because the patient's condition is very unstable, the patient should be monitored more closely. Every 30 minutes, the blood pressures may be measured initially until the patients become more stable, and then we can then relax to the standard monitoring protocol. So after the initial 2 to 3 hours or so, when the patient stabilizes, one can then revert to the stable monitoring protocol, where blood pressure, pulse, oxygen saturation, fetal heart rate are measured every hour, and urine output also measured every hour.
Doctor, if maybe you can start wrapping up in the next 5 minutes, that would be great. Thank you.
Thank you very much. So these are just some examples of some of the protocols that we use in my department. We have the hydrolysine protocol. We have the labetalol protocol. These are the protocols that we use. Next slide. For acute control. But one of the protocols that I would like to talk about is the plain nifedipine protocol. A meta-analysis by Shika et al. And a systematic review has shown that oral plain nifedipine achieved treatment success similar to that of hydrolysine and labetalol, with only less than 2% experiencing hypertension. But we know that experiences of hypertension are complications that are common with the use of hydrolysine and also with the use of labetalol. But nifedipine is therefore relatively safe. And the safety lies in the fact that it can even be used by people in the sub-district and also at the district level as initial treatment even before the patients are transferred. In terms of timely intervention, we achieve this through the establishment of triage and empowerment of staff and emergency preparedness. Next slide. The objectives for establishing emergency preparedness in my department, one of the ways we achieve this is staff empowerment, making sure that the frontline staffs are trained to know what to do when the emergencies arrive, to ensure sustainable availability of emergency drugs. And this is very critical. In our part of the world, you can have situations where the patient may arrive maybe in the night, but magnesium sulfate may not be easily available, or hydrolysine or labetalol may not be easily available in those times of the day. So it is important to establish a system during which you can be sure that at any point in time, these critical emergency drugs are available within the emergency to be used to save lives. We also established a 24-hour dedicated emergency staff. So they are there waiting to receive emergencies like people with severe hypertension in pregnancy. A system also to facilitate reception of the emergencies, and then establishment of trigger system to call up seniors, because the frontline staffs have been empowered to initiate management. It's also important for us to teach them where their limits are, so that they know when to call for help, when to call the doctors, when to call the specialists to come in to help. And then we also established linkage of teams on WhatsApp platforms for rapid communications. So what is done is that when a patient arrives and this patient is critically ill, it is immediately put on a WhatsApp platform so that everybody knows that we have this particular case within the department who have severe preeclampsia with this level of blood pressure. And so that once the specialists and the doctors on duty know that they have this kind of case on hand, then they make their own journey towards the emergency. Apart from these, there are also important operational issues that we should look at. It is important to carry out leadership development, training some of the midwives to be able to coach others, training them in compassionate care, creating leadership ambassadors, perinatal leadership forum, and other clinical champions, so that people are able to develop interest in management of certain specific emergencies. It is also important to make sure that quality improvement initiatives are implemented, the use of multidisciplinary and multi-professional teams to ensure holistic care of the patient, and monitoring and evaluation and aggregation of critical data. So in terms of severe preeclampsia, these are some of the data that we have been able to accrue since 2016 from my institution. You can see particularly that the eclampsia, the number of eclampsias that we receive generally are on the decline from 94 in 2016 to 54 in 2020. Unfortunately, in 2019, there was an upsurge of cases of eclampsia, but that has quickly come down in 2020, and so there is a decline. There is also generally a decline from 2018 of preeclampsia cases with severe symptoms. These are categories that are classified as severe, and as you can see, the incidence is on the decline also. And then that generally, the others have not much decline. When we talk about the total, you can realize that that is also generally on the increase. In 2020, my institution alone received 2,015 cases of hypertensive diseases in pregnancy. Now, it is important to analyze data appropriately to show whether there is improvement or not. So we decided that we will calculate trends in case fatality rate. So how many cases of hypertensive diseases did we receive, and how many cases are surviving? That is the crux of the matter. So as you can see, we have the total delivery number of hypertensive diseases are dead. We also have total maternal death, which over the 5 years has not changed so much. And then we also have number of deaths from hypertensive diseases over them. But what is more important, very important to note, is that generally hypertensive diseases contribute around 50% of maternal mortality. In 2018, it contributed 55%, and this reduced to 33%, and in the last year, it reduced to 26.7%. But interestingly, case fatality rate has reduced significantly. It was 1.3% in 2016. There was an upsurge in 2018. But at 2019 and 2020, you can see a significant reduction to 0.73% and then to 0.39%. Next slide. It is clear from data presented that improvement can occur when a number of strategies are implemented systematically in lower middle income country settings. Our best hope currently lies in early detection of the condition, application of effective treatment protocols. Operational issues such as leadership development, quality improvement systems, and employment of multidisciplinary and multi-professional teams are critical. Ultimately, we need to aggregate appropriate data to show whether there is progress or not. Thank you very much for listening. Please let me have your questions and contributions. Thank you. Over.
Thank you very much, Dr. Emmanuel, for a great presentation. And thank you for our participants who are busy posting some things in the chat. So for the questions, we will take both Dr. Emmanuel's questions and Dr. Ishaku's questions after Dr. Ishaku's presentation. But you can so long post the questions for Dr. Emmanuel in the chat. So now I'm going to introduce the next speaker, who is Dr. Sizwe Ishaku. Dr. Ishaku is a physician and a reproductive health specialist with background in obstetrics and gynecology with 20 years experience in clinical and public health. He worked across all levels of healthcare systems in Nigeria, implementing programs aimed at preventing death and childhood illnesses, maternal mortality and morbidity, and also increasing access to family planning services, and of course, advocating for policies that improve the lives of women and children. He worked as Nigeria's partnership lead for the Women's Integrated Sexual Health Project. And he's also a recipient of the prestigious International Ford Fellowship Programs, Compton Foundation Fellowship, and the Global Health Fellowship Award at Julius Center for Health Science and Primary Care. Dr. Ishaku, thank you for honoring our invitation. The floor is yours.
Oh, great, thank you. Thank you everyone who is online with us this afternoon. So my topic now, I'll focus on improving quality of care for women after delivery. And I'm going to write on what other presenters have said because we have learned a lot already. Next slide. So quality of care after delivery, but frequently these many countries in Africa and elsewhere, because in general, there are two issues here. Generally, in our setting, as soon as the woman delivers, the attention is moved to the baby immediately. And both the parent and the healthcare providers, the nurses midwife, carry the baby and take the baby away. And the woman is left there for some hours before somebody returns back to her. Even the family members and the husband, once they hear that the woman has delivered and they find out what is the sex of the gender of the baby, they are gone. So women usually, and the care for women usually after delivery is relaxed. So that is one component. Second component is that there is this traditional communication that preeclampsia is a disease that is only cure after delivery. And once women deliver, then everything gradually revert to normal. And that really creates sense of false, a kind of assurance, and then everybody relax on the care. And this sometimes goes very bad. So as a result, preeclampsia complications in postpartum period are associated with worse mortality and morbidity. And globally, 60% of maternal death occur in the immediate postpartum period. And when I look at the UK most recent confidential inquiry into maternal death and morbidities, the report in the triennium 2015, 16, and 17, of the 5 deaths that occur due to hypertensive disorder and pregnancy, actually 4 were during postpartum period. That shows you how huge postpartum morbidity and mortality contribute to the overall HDP mortality and, of course, maternal mortality. And in addition to peripartum complication, HDP also confers predisposition to chronic ill health condition in the long term. So when you look at this scenario, it means that postpartum care, monitoring and follow-up are equally very important if you need to improve the care for women with HDP. And it's not only the care that is important, but also the quality. So the care we give must also be of the desired quality. So in trying to address this quality of care, I have taken this paradigm, the framework given by Donabedia. When I saw Truka's presentation, I know she's going to tell us about the WHO framework, which is the most up-to-date, the most comprehensive. But I choose this one because it allows me to discuss what I want to say in a way that my audience will understand what I'm talking about. So quality of care, by definition, defines as the degree to which health services for individuals and population increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So everything that we do must be up to date. What is known to work elsewhere must be delivered to any woman anywhere. And quality of care based on the Donabedian framework is actually consists of 3 triads of structure, process, and outcomes. And the setting, qualification of system through which care takes place, while the process is the content of care, the component of care that was actually delivered, and the outcome is defined as the recovery, restoration of function, and survival. So this is actually similar to the WHO framework that we have seen before, although the WHO is more updated and more comprehensive. But also, the structure and the process and outcome are not the only thing that we need. This thing must revolve on 6 pillars of quality. The care, safety is important, effectiveness, patient-centered, timeliness, efficiency, and equity. Without these 6 supporting pillars, the structure, the process may. So what is the ideal structure for HDP management after delivery? So one, I will start by saying that all units managing HDP should maintain and review uniform departmental management protocols and conduct regular audits of maternal and fetal outcome. And Dr. Emmanuel has discussed extensively how they use protocols in their hospital, but you agree with me, in many facilities in developing countries, from tertiary to primary healthcare center, protocols are not available. Even if they're available, nobody uses them. And when it comes to HDP, preeclampsia, eclampsia, commonly the protocol that we use WHO protocol in Africa, but the last protocol, WHO protocol on preeclampsia, eclampsia did not speak extensively on postpartum management. But I know that there is ongoing protocol that is coming out, which I understand that is going to include postpartum care. Maybe it's out. I have not seen that one yet. But in the interim, the International Society for the Study of Hypertension and Pregnancy has developed a protocol, a guideline for international practice, which is what I quoted here as Brown et al. It is actually titled as Hypertensive Disorder and Pregnancy, ISSP classification, diagnosis, and management recommendation for international practice. I recommend everyone who is taking care of women with hypertensive disorder to get that protocol and use them, depending on when WHO is out, protocol is out, and then we'll use them together. I believe that they will improve the care we give. Secondly, the facilities where women are attended postpartum after HGP should have the minimum equipment and the tools and the medication, and also the capacity to provide comprehensive obstetric care services, including maternal critical care. This is very important as a structure of where we manage women after delivery. And next is the competency and the skill of the healthcare providers. Before 2018, we generally use skilled healthcare provider as an indicator of the kind of personnel we want to see in our facilities. But however, the definition of who is skilled healthcare before 2018 was not very clear. We generally assume that when you have a doctor or you have a midwife or nurse at the facility, that person is skilled. But that is not the case, because it has been shown that the availability actually in low income country did not actually is not associated with decline in mortality and morbidity. So the new definition of skilled care actually is not giving emphasis on whether the person is a doctor or the person is a nurse or midwife. No, there's a competency that once the person acquired those competencies, then that person is considered skilled. So it's not whether the person is a nurse or a midwife or a doctor. No, whoever is there should be competent on the identified issue. When we're talking about HGP, that person must be trained and mentored to provide services for women with HGP during pregnancy, during delivery, and during postpartum care. That is the skill we're talking about. They must be educated, trained, and regulated to national and international standards. Supportive enabling environment must be available so that this personnel can actually do their work competently. And this is actually communicated through a joint statement in 2018, joint statement by WHO, UNFPA, UNICEF, ICM, ICN, FIGO, and International Pediatric Association. Then what is the ideal process? The process we say is the content of care that we give to this woman. And in this content of care, we generally focus on the care that we deliver. We don't consider that we deliver care on women who are human beings who need to be carried along in the process. So in this presentation, I divided the kind of information we give to the women, the immediate information before we start giving care, and the final information after we deliver our care. So that women need with HGP is that women in many of our countries have limited comprehension of the nature and risks of the disease. If this nature is explained to them and they are carried along, they are going to collaborate and cooperate with the system, and the outcome is going to be great. Also, all women should be reminded of the danger sign of preeclampsia, flowing birth. So once women deliver and they have hypertensive disorder and pregnancy, they should be informed that these are the signs that indicate ominous outcome, and that they should raise alarm. Something like maybe they have blurriness of vision, dizziness, chest pain, and vomiting or nausea. These are all signs indicating that something dangerous maybe is around the corner, so they should know. And also, whenever blood pressure is measured, patients should be asked specifically of this danger sign, because they can be experienced, but if women are not educated or they are not asked, they are not going to talk about it. women with preeclampsia should be considered at high risk for preeclamptic complication, at least especially between the 3 and 5 days after delivery. During this window period, between 3 and 5 days of delivery, blood pressure can rise unexpectedly very, very high, and serious complications like ischemic heart disease or stroke can occur during this period. So women should be informed that this window period is very important in their care. Management of women with HDP who wish to breastfeed should be adapted to their preference. So, for example, if women want to breastfeed, they should know that breastfeeding is not contraindicated, and antihypertensive also are not contraindicated. They can take their drugs. Most of these drugs, even if they are secreted in breast milk, they are in a low quantity that they are not expected to cause any harm to the infant. So this treatment should continue, and women should know that they are safe. And also, women with preeclampsia or HDP after delivery, they may need painkillers for their own pain management. So if possible, we should not give these women non-steroidal anti-inflammatory drugs because some of them are associated with increased worsening hypertension and also effect on the renal system. But unless if there is no any alternative, then this kind of drug should not be given for women during this period. Next slide. So now I'm talking of the component now properly. What do we need to do when women deliver with preeclampsia or any kind of HDP? So on the first day or first and second day of delivery, we have to check the blood pressure of women with chronic hypertension and gestational hypertension every day. And for women with preeclampsia and eclampsia, we must check the blood pressure 4 times every day. And when we check the blood pressure, we have to communicate the finding to the women and to the providers, and they must know what needs to be done, and what needs to be done must be done. Not just to check the blood pressure and document it and go away, because that's what we do. Check the blood pressure, document, and go away. In many cases, we don't check. And women with preeclampsia and eclampsia are lumped together with women with gestational hypertension. We check blood pressure once, and that's it. In their own case, we have to check 4 times every day. And as I said before, during day 3 to 5, at least all forms of HDPs, we must check the blood pressure once during that period. And once the blood pressure is high, we must continue our antihypertensive. Any woman with blood pressure of 150 over 100 millimeter of mercury need to be on antihypertensive. And our target is that the blood pressure must be lower than 140 over 90. In fact, some strict recommendation is even recommending that the blood pressure should be lower than 135 and 85 millimeter of mercury. But this is what should be done. But we are talking about quality. There are practical issues that we have to know to be sure that the blood pressure that we measure are accurate. For example, we can't just take blood pressure when the women are not relaxed. We have to make sure that the women are relaxed and at least 5 to 10 minutes of rest before we check the blood pressure. And when you look at the slide, I have listed a lot of other criteria that we must ensure that they are fulfilled before we take blood pressure. If not, we are going to get readings that are misleading, and we will not be able to manage the women adequately. So this is just an example from the study in Nigeria that we monitor women, about 400 women, and after HDP, and this happened in tertiary hospital. And you can see that we track them to see among these women, how many have their blood pressure measured from day 1 to day 5. And you see that by day 3, only 1/3 of the women actually had their blood pressure measured. On day 1, both blood pressure and proteinuria is reasonably high, at about 80% and above of these women had their blood pressure and protein measured. But from day 2nd onto day 5, progressively you can see declining adherence to what we should be doing. This is just to give you the example of what can happen at the lower level. This is at the tertiary hospital. In this slide, we look at the proportion of women whose blood pressure was at least 150 over 100 millimeter of mercury, who should be on antihypertensive medication, but only 2/3 are actually on antihypertensive medication. That shows you that the adherence to the need for antihypertensive after delivery is not observed, even at tertiary facility. And then what could happen at the lower level can be very, very bad. In this slide, I also, from that study, we look at the women with preeclampsia and after delivery, that at least we should measure their platelet, transaminase, and serum creatinine within 2 to 3 days after delivery. In tertiary hospital in Nigeria, in our cohort, none of the women actually had this investigation done. So you can see how very poor the quality was. And also, women with HDP at 6 weeks, that is the standard. All pregnant women after 6 weeks after delivery at the end of the period usually have comprehensive review. And this is even more important in the case of women with HDPs. In this, our cohort, in Nigerian hospital, teaching hospital, only 46% of women actually had this review for them. Also, we look at women with gestational hypertension and preeclampsia who remain hypertensive 2 weeks after discharge and were offered medical review. Only 24% had these services. We look at urine protein estimation using this stick 8 weeks after birth, and we notice that only 42% of women had these services delivered. And of course, you know that preeclampsia, especially when it associated with other risk factors, for example, high maternal age or obesity or high parity, is also associated with thrombosis. And thrombosis is the cause of maternal mortality in Europe and America. It's one of the leading causes of maternal mortality. And it also happens in our society, even though we don't diagnose it. So it is very important in these women that they are given thromboprophylaxis, which is available in all our countries. But in this, our cohort, only 7% of women got these services. And we're talking about teaching hospitals. So you can see you can predict what can happen at the general hospital and PHC, where 80% of women receive their services. And of course, we should not forget that these women also need a mental health review and assessment and treatment, as was discussed yesterday. After the immediate period, women with preeclampsia have need for long-term follow-up because there are associated complications that can happen in the long term if these women are not followed long term. Certainly, up to 6 months to 1 year should be enough. These women can continue to have huge complications. What is important is that women after delivery, women with HDP should be advised to maintain a normal body weight range. The BMI should be between 18 and 24 square, and the women should be counseled on family planning since from during pregnancy, during delivery, and after, because they need to recover very well before they embark on the next pregnancy. And also, women should be informed about the risks of occurrence of HDP in the next pregnancy. In general, is about 20%, but it may increase with the HDP types. Example is the risk of occurrence is higher in preeclampsia and eclampsia than in gestational hypertension. And women with HDP should be advised that they may have persistent hypertension in their life. So the notion that hypertension will disappear after delivery is not completely true. In our cohort of women that we monitor up to 1 year in Nigeria, more than 400 women who follow them up to 1 year, we discovered that women with preeclampsia, 60% of them continue to have high blood pressure after 1 year, and 20% of women with gestational have high blood pressure after 1 year. But we know that these women are high-risk women because there is high rate of obesity among them. So we know that these are high-risk women. Our finding of 60% may not apply to all women. And also, we know that some of these women may be carrying hypertension in their life, which we didn't know before they became pregnant. And because they didn't come to ANC early, they came after second weeks, 20 weeks. So we couldn't distinguish between chronic hypertension and gestational hypertension. That may be the reason why it is very high. But what I want to say is that women should know that hypertension after pregnancy following HDP does not disappear as we think. We have to monitor them until it is satisfied that this woman's hypertension has gone away. But then also, HDP is also associated with future cardiovascular diseases. But luckily, before women progress to cardiovascular diseases, there is intermediary metabolic state that women usually pass through, and it's called metabolic syndrome. So if women are screened for metabolic syndrome early after HDP, we should be able to detect metabolic syndrome and manage it appropriately so that they don't progress chronic to cardiovascular heart disease. And metabolic syndrome, and I don't have it on my slide, but there are many definitions of metabolic syndrome, but I want to limit myself to the definition by the International Diabetes Federation because it is easier to diagnose in Africa. It only requires BMI, no letter BMI, hypertension, and blood lipid. So once you do that, you should be able to know women with metabolic syndrome, and we can manage them. We can manage their BMI, manage their hypertension and lipid abnormality. And with good management, we should be able to manage them. We recommend that women as early as 3 months after delivery, they can start screening for metabolic syndrome so that they can detect this risk factor that will lead them to chronic heart disease later in life. Women also must be informed that they are.
Sorry, Doctor, please wrap up in the next 2 to 3 minutes, and then some of the issues you can address them during the question and answer session because there are already questions for you. So please wrap up. Thank you, Doctor.
Thank you very much. One thing is that women should also be advised of the risk of chronic kidney disease. It also in our own cohort, 6% of women had chronic kidney disease at 1 year after HDP. But generally, if the protein in the urine is negative after 2 weeks and women are not hypertensive after 2 weeks, we assume that women are not going to have, and the risk of chronic kidney disease is very low. And then finally, the outcome of a pregnancy is that we want to have healthy babies with impaired mothers, with the mothers whose health is impaired. And of course, every hypertensive pregnant woman should be offered an opportunity to participate in research, clinical trials, and follow-up study. So this is my last slide, hopefully, but I want to illustrate here that we can achieve zero mortality from HDP in Africa. This is the example from the UK. You can see that in 1953 to 52 to 54, in that 3 years window period, about 200 women died from HDP in the UK. But in the last triennium, 2015 to 17, only 5 women died in the whole of United Kingdom, including Ireland, out of 2.2 million pregnancy and delivery. And this is because of availability of guidelines, and personnel are trained and they are evaluated, and everyone is using the guideline to make sure that the quality is maintained. But even in that society, they still have challenge with aspirin prophylaxis that we talk about, because of the 5 women that died, 4 of them actually needed aspirin prophylaxis, but they were not given. And that might have contributed to their complication. So in summary, HDP continue to place huge burden on maternal survival in our setting. Quality of care provided in this setting is a suspect, especially after delivery, when majority of mortality and morbidity occur. Improved care quality based on laid-down protocols must be prioritized. Long-term follow-up is necessary to detect associated chronic health conditions. Next slide. And in conclusion, to reduce the HDP-related morbidity and mortality in our setting, improving quality of postpartum care is crucial. Quality of care provided should be appraised based on the triad of structure, process, and outcomes, with all the supporting pillars of quality that we talk about: the safety, efficiency, women's center, equity, and efficiency. Thank you very much.
Thank you very much, Dr. Ishaku, for a detailed and excellent presentation. I will now move to taking questions that were posted in the chat. So these questions are not specific to either you, Dr. Ishaku, or Dr. Strofenyo. I will just ask them as they come, and Dr. Emmanuel Strofenyo and you, Dr. Ishaku, you can answer wherever you see fit. So the first, overall, there's a challenge that in Africa, we don't really have standardized training or the entry requirements that match the international expectations or standards are not there. We don't see those international standards in Africa, and even the guidelines are not very consistent. So it's overall the challenge that people are experiencing. So if you can just first comment on that, is there anything that is being done by different society stakeholders to arrive at a standardized way, uniform of way of doing things, maybe in a country or between different countries or overall in the region? Is there some form of work going into that?
Yes, I think we discussed this issue in the past, and we know that when we look at WHO guidelines for preeclampsia, eclampsia, and we notice that there was no recommendation for postpartum period, but we know that the WHO is revising that guideline. But then we quickly collaborated. At that time, I was working with for Indian Eclampsia project, and we collaborated with International Society for the Study of Hypertension and Pregnancy, and we quickly developed a guideline which we believe is adequate for international practice and is actually relevant for what we can do in Africa, and it conveys guideline and recommendation based on international practice. And it's a title as hypertensive disorder and pregnancy, ISSSP classification, diagnosis, management recommendation for international practice. So we can use that one in the interim, and also the WHO guideline, once available, the two can be combined together, and I believe this should be adequate for our setting. Emmanuel, go ahead.
Thank you very much. I do agree with all that you have said. On our part, we don't have any national standardized protocol, but we do have a regional protocol. With the experts within my region, we have come together and put together a standard protocol, which is now binding on all the facilities that are within the region. The national team is looking at it to see whether this can be elevated and updated to create a national protocol. It is out of this that we have created the institutional protocol, because at the institutional level, the emphasis is more on the use of the medications and what medications to give at which time, and so on and so forth. So definitely, a time has come that protocols might be elevated so that the same thing is done across the entire country. I agree fully with you.
Just following up on that, and Prof. Dr. Manuel, you can answer these two questions for us. One is that what is the current protocol for labetalol and hydralazine? And then the next question is, why should we avoid using non-steroidal anti-inflammatory drugs postpartum? Those are the two questions. The current protocol on labetalol and hydralazine, and why non-steroidal anti-inflammatory drugs must be avoided postpartum. Dr. Emmanuel, please answer these two for us, and then the other two I'll reserve for Dr. Ishaku.
Thank you very much. The labetalol protocol, the particular protocol, that is, we are talking about protocol for control of acute hypertension. If a pregnant woman comes with severe hypertension, there are two protocols that we use. There is one that we call the 10-20-20-40 protocol. So once the patient passes the initial assessment, she has no history of heart cardiac failure, she's not an asthmatic, then she could be suitable. And so we use initially IV push 10 milligram, and this is repeated in 30 minutes, 20 milligram, and then another 20 milligram. And if at this point the blood pressure is still high and is still above 160/110, that is when we now elevate it to 40 milligrams. So we call it 10-20-20-40 milligram protocol for labetalol. And this is very simple and easy to remember, and it is on the chart, my presentation slide, that you can easily have access to. As far as the ranges are concerned, sometimes the women may come with very severe hypertension. Let's say BP values reading above 200/120. In such case, we start with a slightly higher dose of 20 milligram labetalol. So there we do 20, 20, 20, and 40 milligram protocol, making sure that we do not exceed 200 milligram within the acute phase. So that is the protocol that we normally use. Then in terms of hydralazine, again, depending on the severity of the blood pressure, for those whose blood pressure is below, the systolic is below 200 and the diastolic is below 120, we start with 5 milligram every 15 minutes, 5 milligram push every 15 minutes until the targeted blood pressure is achieved. However, if the blood pressure, if the patient comes in with severe hypertension of the systolic more than 200 and a diastolic more than 120, we start with 10 milligrams. This adjustment came about because we have realized that when we use the standard acute protocol of 5 milligrams over the period, it takes too long for the blood pressure to eventually begin to come down. And that is why for those with severe hypertension, systolic more than 200, diastolic more than 120, we use a slightly higher dose at the initial start and then later on normalizes to the standard doses. Now, the second question, these drugs, non-steroidal anti-inflammatory drugs, do have a lot of side effects, and some of them has to do with the kidney. I do know very well. And so therefore, because individuals who have had severe preeclampsia, some of them may have some residual kidney complications, which we may not know. And therefore, that is why it is advised not to use it, because the evidence is there that the Western kidney complications, so that is why generally it is not advised. And indeed, people who have kidney disease, let's say chronic kidney disease and so on and so forth, are not advised to use non-steroidal anti-inflammatory drugs. These drugs themselves, if abused, can cause chronic kidney diseases. Even if you do not have preeclampsia, if you abuse non-steroidal anti-inflammatory drugs, you may end up having kidney diseases. So this may be the foundational reason why it is advised for them not to use it. Thank you very much. Over.
Dr. Emmanuel. So Dr. Ishaku, the two questions, last questions that we will close the question and answer session with for you is that the first one is what causes these huge variances in compliance rates that we observe and you've also presented in your work. And then the second one, which is the last, is what is the role of clinical laboratories in improving the quality of care for women with preeclampsia?
Thank you very much. I think the reason for the low compliance is just because we don't have protocols, and also many providers are not aware of those protocols. Providers are not mandated to use them. People just practice the way they want to practice. This is the case in Africa. In many places, there is no, it's not binding that provider must use the protocols. So that's why going forward, every facility must have protocol, and providers must be trained to use the protocol, and we must evaluate and appraise to make sure that protocols are being used. And the reason for any intervention is communicated to the patient. They are going to comply, and we are going to have a high compliance. I think that's generally the reason why we don't comply. And of course, there are a lot of clinical laboratory in this. In fact, they are at the center stage of everything, because there are a lot of things that physicians and midwives and nurses cannot do without the support of the laboratory services. We are talking about you have to know the creatinine at any point in time. You want to know the transaminase. You want to know the lipid profile. This must come from the laboratory. So they must also be carried on. And it's very important that they should know, because the way we practice in Africa, professionals work in isolation. We don't work as a team. Sometimes a lab man is working in the lab. He's not engaged, he's not involved in the patient care because he doesn't see the patient. So he does his thing the way he wants to do it. He reports what he wants to report. There's no teamwork together. So the nurses, midwives, the radiologists, doctors, physicians, everybody must be on board to work together as a team, and everyone must know what is happening and how they can play a role.
Thank you very much to both of you, Dr. Ishaku and Dr. Srofenyo, for your very insightful presentations and your answers to these questions. So for other questions regarding protocols and the drugs, participants, I will encourage you to just look at the slides for these two presentations again, because they did provide some detail. And I also see that in the chat room, some people are responding to the questions. So please keep the questions and the thoughts going in the chat room as we move now to the second last speaker for our conference, which is Dr. Ingrid Gichere. Dr. Ingrid obtained her undergraduate degree in medicine from University of Copenhagen, Denmark. After moving to Kenya in 2007, she started working within the public health sector before she proceeded to her postgraduate training in obstetrics and gynecology at Aga Khan University in Nairobi. Since she graduated in 2015, she has been attached or working together with Aga Khan clinics, and she has a special interest in medical complications of pregnancy with focus on lifestyle-related diseases, including obesity. Her aim is to create awareness about non-communicable diseases during pregnancy and to further generate knowledge to aid the prevention of short and long-term complications. Dr. Ingrid, thank you very much for your time. Over to you.
Thank you. As you might can hear, all of you, my voice has really taken a hit today. So I hope you can still hear me. And if there's some coughing, I apologize. So I have been given the honor to talk about non-communicable diseases, hypertensive disorders of pregnancy, risk factors, and long-term complications. And as you might can hear from the introduction of myself, this is one of my sort of main interests. I was thinking about doing this presentation because we have like a very mixed audience, which is really interesting. And I think us doctors and healthcare providers, we talk to each other a lot. So I will take this opportunity to talk to the patients and the survivors of preeclampsia as well. So I'm trying not to use too many medical terms. And if some of the medics think it's too simple, then I apologize. So my outline, I'll talk about non-communicable diseases, a bit about the world, and then among Kenyan women who are our patients in the obstetric field. And then I'll talk about the shared risk factors for preeclampsia and NCDs. And I'll talk about pregnancy as a biological stress test, which is one of the things Professor Maki also mentioned. And I'll bridge on the pathophysiology of preeclampsia, which is complex, but I'll talk a little bit about who is the victim and who is the culprit. Is it the placenta or the cardiovascular system? And then in the end, we'll talk about the long-term complications of preeclampsia, which we've also heard about before today, and that the disease does not stop by the end of pregnancy. So what is the burden of NCDs? I'm sure you know about the global epidemic. And NCDs are the cause of death for 41 million people annually. And each year, 15 million people aged 30 to 69 years die from NCDs. And unfortunately, 85% of these premature deaths happen in low and middle income countries. And 77% of all NCDs related deaths happen in low and middle income countries. As you can see on this map from the World Health Organization, Africa is red, meaning that we do lose way too many young lives due to NCDs. And it's not only men, 1 in 3 women die from cardiovascular disease globally. So what about NCDs among Kenyan women? And the numbers are also high here. A recent survey to look for NCDs in the Kenyan population showed that 24% of Kenyan women, that's 1 out of 4, had hypertension. But unfortunately, only about 22% or 1 out of 5 were actually aware of their condition. And out of the ones who are aware, only 28% were actually on treatment. And out of the ones who were on treatment, 55% had well-controlled blood pressure. And if we look at diabetes, 2.3% of Kenyan women had diabetes, but only 43.7% were aware of the condition, and only 1 out of 5 of these were on treatment, and 7% had good blood pressure, blood sugar control. And now overweight and obesity, which is sort of one of my main interests among Kenyan women, there's a prevalence of 29.6%. And I know that this is also the case for many other African countries. So 40% of women between 25 and 44 years, that's our reproductive years mainly, are overweight or obese. And in Nairobi, the capital, it's 47.8%. And unlike many other Western countries where there's also an obesity epidemic, in Kenya, it's mainly among women with higher education and who have a good income. So with higher education, we saw 45.7%, and among the wealthiest, it was 50.1%. And I can say this is reflected a lot in our clinical practice. In Aga Khan Hospital, where I work, which is a hospital that caters mainly for the middle and higher income classes, at booking for antenatal care, we had 37% of patients who were obese and 31% who were overweight, and only 2% were actually underweight. So it's a problem we see every day, and I think it's a problem we don't talk enough about. So this presentation is mainly going to look into how NCDs and hypertensive disorders of pregnancy, they are connected. And I will start with this slide where we look at the risk factors for developing preeclampsia, and I'm sure many of you know this. So if you look at the major risk factors, history of preeclampsia, autoimmune diseases such as SLE, diabetes, chronic hypertension, chronic kidney disease, and moderate risk factors, we have first pregnancy, maternal age more than 40, obesity, family history of preeclampsia, last pregnancy more than 10 years ago, twin pregnancy, and African race. And then if we sort of cross over preeclampsia and look at NCDs, what is the risk factors for developing NCDs? They are very similar. A history of preeclampsia in itself is a risk factor for developing NCDs, autoimmune disease as well, diabetes, chronic hypertension, chronic kidney disease, maternal age or age in general, obesity, and unfortunately also African race. So NCDs and preeclampsia share many risk factors. And that's interesting. So if we look at the risk factors for developing preeclampsia, and this is in odds ratio, we can see here diabetes, chronic hypertension, a BMI in the overweight group, 25 to 30, BMI of 30 to 35, which is class 1 obesity, BMI of 35 to 40, class 2 obesity, and above 40 is class 3 obesity. Then at the end, African race, just to remind us that we do have a higher risk factor of developing preeclampsia here. So overweight and obesity is the most important risk factor for preeclampsia with an attributable risk of 64%. And that's also what Prof. McKee said earlier in her presentation. And why this is interesting is actually that overweight and obesity is one of the modifiable risk factors, something we might be able to do something about. And when we say attributable risk percent, it means that if we could remove all overweight and obesity, we might be able to remove 64% of preeclampsia cases. So why is this? So what is the link between NCDs and preeclampsia? So I want us to ask ourselves, among these two women, who would perform best in a marathon? I think we would all point towards our Kenyan athlete and not on the slightly curvy lady. So if we now put this in the context of pregnancy, pregnancy is actually a 40-week-long metabolic and cardiovascular stress test. And that allows us to sort of get an idea about what can happen to this woman in the future, because the way pregnancy does to our body gives us an idea about how this the risk of NCDs are in this woman. And if we look at this graph, you can see that in the course of pregnancy, there are so many things that changes in the heart. For example, the cardiac output, which is the dark blue line, increases with 50%. The stroke volume, meaning how much blood the heart has to beat, it goes up by approximately 30%, and the heart rate goes up by 20%. And then we can see the graphs that are going down, that's the hemoglobin and the total peripheral vascular resistance. So all this really puts a lot of strain on the heart. And the same goes for the more metabolic system, where we also have, we can see here the insulin requirements during pregnancy increases quite dramatically. And that's why some women also develop gestational diabetes. So if we look at the pathophysiology of preeclampsia, so as I asked earlier, who is the victim and who is the culprit? Because I think many of you have heard about the placental theory, where we talk about inadequate placentation in the very early days of pregnancy. And that causes placental insufficiency, which now leads to a vascular reactivity cascade, And then in the end organ damage, such as hypertension, proteinuria, HELLP syndrome, and eclampsia. The problem with that theory is that it's true, especially for early onset preeclampsia, but we do not see these changes in the placenta for all preeclampsia patients. So alternative theories have come up that maybe it is actually not the placenta which is now hitting on the cardiovascular system, but the other way around, that the cardiovascular system is already sick when this woman gets pregnant. As we talked about before, a pregnancy is like a marathon. So if you have a poor cardiac reserve pre-pregnancy, you might not do very well. So there's a relative imbalance between the cardiovascular reserve and the cardiovascular stress of pregnancy. And that is now what might cause placental oxidative stress. And then we get preeclampsia. So both theories are probably true, and they don't exclude each other. But it's just interesting to look at it that way as well, and that might make us understand why we don't find these placental changes histologically when we look at the placenta, because it might actually not be an abnormal placentation per se, but that the system, the pre-existing system in the woman was not able to cope with pregnancy and all the stress it puts on the body. And I just want to show you this slide as well, because that's a question I get quite often. So why is it that obesity can cause preeclampsia? I mean, it's just some fat on the side. And the problem with obesity is that it's linked to insulin resistance, and that causes like a chronic inflammatory state in the body. And that chronic inflammatory state can cause abnormal spiral artery remodeling, which is part of the placentation. And that leads to placental hypoxia and release of anti-oncogenic factors, which now causes endothelial dysfunction, which means dysfunction of the vessels in the body, which eventually leads to preeclampsia. I just want to show you this as well. It's not to do with preeclampsia alone, but just to let you understand the adverse pregnancy outcomes that is linked to obesity. It's not preeclampsia alone at all. As you can see, many of the main complications of pregnancy are increased in women who are obese, such as miscarriage, gestational diabetes, gestational hypertension, preeclampsia, fetal growth restriction, deep venous thrombosis, pulmonary emboli, cesarean delivery, wound infection, and stillbirth. So if we can do something about obesity, then it's not only preeclampsia we can do something about, it's also many other pregnancy complications. So where are we right now? So I think in our setup, at least in Arakan Hospital, we have improved a lot on preeclampsia management. That is not countrywide, or of course not all over the continent, unfortunately, as we've been told in the other presentations. We do follow our patients up to 6 weeks postpartum with blood pressure control. And I think we also become quite good in informing our patients about the risk of recurrence and the benefit of aspirin 150 milligrams in the subsequent pregnancies. But I think then things stop. Yeah, we are not good in talking about long-term follow-up and the risk that preeclampsia poses to that woman long-term. I think many times we even tell her that the minute your placenta is delivered, then the disease is sort of over. So you don't need to worry after the delivery, but that is actually a lie. And we need to talk much more about that because preeclampsia gives us a glimpse into what can happen in the future for this specific woman in terms of NCDs. So the problem is that there are long-term complications of hypertensive disease in pregnancy. There are high risk of developing NCDs later in life. As you can see here, if you look at the various conditions, the odds ratio for hypertension is 3.7 on average. It depends on which kind of hypertensive disease or pregnancy you had and how severe it was and how early the onset was. The more severe, the more early, the higher the risk later in life. And the risk of ischemic heart disease is also markedly elevated, the risk of stroke, venous thromboembolism, and diabetes. So this is something that we need to talk to patients about. And maybe instead of focusing on it as a bad thing only, we can also look at this as an opportunity to actually change your lifestyle because it gives you maybe an idea that if you don't do anything, then this might happen later in life. So this comes to how can we utilize this knowledge? And as was mentioned in the previous presentation, women with a history of preeclampsia or other of the main obstetric diseases, such as the fetal growth restriction, gestational hypertension, etc., we should offer these women annual screening, and that annual screening should include a history and a physical exam, blood pressure, check for high cholesterol, check for diabetes, check for overweight and obesity, and lifestyle modifications such as diet and exercise. And my main take-home message from this talk is that preeclampsia is not an isolated event. It is linked to pre-existing risk factors, and that's where we can set in. There are many questions about how can we prevent this from happening. And I think instead of just thinking about only like risk stratification within the pregnancy and giving aspirin to high-risk patients, we need to look much broader and do something about all our lifestyle issues within Kenya and Africa as a whole. And that's where we can actually do quite a lot to prevent preeclampsia. And then we need to look into the future and try and prevent the development of NCDs in these women as well. So I've put up this slide because how do we do this? And I think, of course, there's a lot of things involved, and it's not an easy thing to do at all. So if we look at culture, for example, and as you might can see in my picture, I'm not Kenyan. I'm married to a Kenyan. I've lived here for 14 years. But what I sort of saw when I started working in obstetrics here is the different sort of the culture ways of looking at pregnancy. And I can tell you in Denmark, we have several stupid things we do as well. For example, one thinks that the baby has to sleep outside in a pram, otherwise it will almost die if it sleeps inside and stuff like that. So it's not only that Kenyan has weird thoughts about pregnancy, it's all over the world. But what I saw here is that there's quite a lot of sort of cultural resistance, maybe to, for example, exercise during pregnancy. It's believed to be dangerous. I did a study on this myself during my years as a resident. And most people will think that that it's dangerous to do exercise in pregnancy, and they're quite sort of worried about it. And even the ones who want to continue doing exercise, they are sort of discouraged from doing so by their husbands or family members. So that's one place we need to discuss. I mean, we need to sort of inform not only the patient, but also her family. And then there are other beliefs such as that you can only have a lot of breast milk if you take a lot of porridge and hot chocolate, for example, post-delivery, which leads to quite a lot of inter-pregnancy weight gain. And also the belief that the baby should not be taken out in the first months of after delivery because that's dangerous. And then what happens is that the woman sits home very sort of on the couch breastfeeding, and she doesn't start moving before much later. So such things we need to address, because of course it doesn't come out of any stupidity or anything. It makes a lot of sense to give a breastfeeding woman. Like if I look at my own mother-in-law, I mean, it made tons of sense. She has 10 kids and work really hard. She should have more calories during her breastfeeding. But in Nairobi, where unfortunately we eat too much KFC and we just sit in our cars, we do not need that. So you need to talk to the patient in a respectful way about those things. Then, of course, genetics, as I mentioned, the African race, there's an increased risk of both preeclampsia and NCDs. And that one we shouldn't change at all, of course. Our genetic background is great. But of course, it's important to know, and it's also important to remember that some of the studies done on this disease are done in the West. And as was highlighted earlier, we cannot always just adapt that to our setting and our genetics. So it's important that we as healthcare providers and policymakers, we invest in local studies which fits our own setup. Then there's the whole lifestyle issue. As I mentioned, we have a huge obesity epidemic in Kenya and in Africa as a whole. And that starts from childhood. We see more and more childhood obesity. And of course, an obese mom creates an environment intrauterine and after birth that gives a higher risk for obesity in childhood, which gives a higher risk for obesity later in life. And then we have the circle. So we need to break that. How that is done, it's hard, but that's also into policy making. Yeah? us as healthcare providers, we need to be much more broad. I think not only talk about, not only see the patient when they are pregnant, as someone else mentioned, the importance of preconceptional advice, especially for high-risk patients. Tell them about the risk of preeclampsia, the importance of aspirin if they have high risk for preeclampsia, and also make sure we link them up with the long-term follow-up, that we don't just leave them alone after the 6 weeks postpartum visit and maybe just wait for the next pregnancy to happen. We need to link them up with the correct people, whether it's cardiologist, endocrinologist, or family physicians, to follow them up annually and talk to them about NCDs in the future. And then, of course, policy making is really important, and that goes both in terms of what was mentioned earlier, like protocol development, and not only development. In Kenya, we actually have a lot of the protocols, but also the utilization of those protocols, that they're not just paper, but actually being utilized, money for research, etc. So I think that was sort of my speech for today. And thanks again for giving me the opportunity. And we'll discuss if there are any questions. Thank you so much.
Thank you very much, Dr. Ingrid, for an informative, insightful, and great presentation that you gave us. And by finishing up with showing us all those factors that are contributing to the hypertensive disorders in pregnancy, what we see with specific reference to Africa. So I really thank you for giving us that African perspective. And I also believe, as you've discussed some of the things, there's always a way with community engagement and reaching out to people at their level, in their language, and being respectful of different cultural and religious beliefs, we can be able to achieve quality of care and promote awareness around preeclampsia to contribute or try and protect these mothers and babies. So our last speaker, but not least for today, is by Dr. Sikolia Wanyonyi. He will be telling us about, I think, something that almost all of us would like to know about. How has COVID-19 affected or impacted on the care of high-risk patients experiencing hypertension in pregnancy, or even maybe not high risk in general? How has it affected patients who are under care or need care for preeclampsia and other things? So I'm just quickly going to introduce to us Dr. Wanyonyi. So he obtained his Bachelor's of Medicine and Surgery degree in 2003, and he went on to obtain his Master's of Medicine in Obstetrics and Gynecology at Aga Khan University in Nairobi. Then in 2019, he obtained his International Master's in Maternal and Fetal Medicine from the University of Barcelona, and the Diploma in Fetal Medicine still from the University of Barcelona. So since obtaining his degree, he has worked as a clinical research fellow at University of Oxford in the United Kingdom, and was a senior instructor at Aga Khan University Hospital from 2014 to 2019. And he is currently an assistant professor at Aga Khan University in Nairobi. Doctor, thank you very much for honoring the invitation and giving us your time. The stage is yours.
Thank you very much. I hope you can all hear me. And it's always not so good to be the last one to speak, because one, many have left. Two, those that are remaining may not listen. So I won't be surprised if you hear 40% of what I talk about. So I took that into consideration when making my presentation. So I'll be as brief as possible. I was given a very hard topic, so to speak, because I think when I looked at it, impact of COVID-19 in response to treatment and care of high-risk patients, I think these are PhD thesis. And for me to be able to deliver this effectively, I think I'll require a mind of a genius, which I'm not. Anyway, I'll try my best. And as following into Ingrid's steps, I'll try to be as basic as possible. And I also apologize for those who may find me less scientific than expected. So, in this presentation, I'll look at the effect of COVID-19 on delivery of maternal health service as a whole. I think it may be better to look at maternal health service because we cannot look at preeclampsia or hypertensive disease in isolation. Then I'll look at how, if there's any association between COVID and hypertensive disease in pregnancy per se. And I'm happy that Ingrid has actually touched on the conflicting theories or the emerging theory of hypertensive disease in pregnancy. And I'll finish off by just highlighting some of the measures that we may put in place to ensure good maternal and neonatal health. So to start us off, I won't bother you much with what you already know. I think many speakers have talked about the extent and the impact of preeclampsia and how it can affect, and most of you have had the experience firsthand, so you know. But in the advent of COVID, there's been so much that has been happening, and there's so much material and resources that I'd like to refer you to, like this website by the WHO, which has most of the information in very simple language that you can understand, both in pregnancy, breastfeeding, childbirth, and all those questions that you may be interested in. So I would welcome you to visit this site. I decided to look at how COVID has affected maternal health delivery using the model of maternal mortality that we use. For those who may not understand, many mothers die in sub-Saharan Africa or in resource limited regions because of 3 delays. So I'll be taking you through each delay and seeing how COVID has actually impacted this. And then I would like you yourself to put preeclampsia or hypertensive disease in this context. So the first delay usually is the delay of the woman deciding to seek appropriate care. So these are women who you have educated well. You've told her that if you have a severe headache or if you have some severe pain on the right side of your tummy, or if you see stirring, then you should immediately come to a health facility. So she knows this, but she really struggles to decide when to go. And there are many factors that usually affect this, that we can look at it differently. But how did COVID, at least in the context of Kenya, and I can assume it's for the rest of Africa and the world, how did it affect these women from actually overcoming this delay? So you have your severe headache, but there is a lockdown, there are curfews. And for instance, recently we had a curfew from 8 to 4, and people were stopped on one of the major highways at 7:30 because they are running late home. So you can imagine, you hear that on the news, and then you have a headache, and then you want to go to the hospital. So those are some of the things that will influence your decision. Yeah, then you think, maybe if I go to the hospital, I'll find the hospital is closed or the clinic is already closed because the workers are leaving early also to go home. Or if I go to the hospital, I may contract COVID because I hear that hospital is full of patients with COVID. So is this headache so bad that I should go to the hospital and risk getting COVID, or do I just stay at home and watch? So these are some of the things that a pregnant woman who is at high risk goes through asking. And this actually leads to the first delay that would lead to increased morbidity and mortalities. Then we go to the second delay, and the second delay is you reach how do I reach appropriate facility? So I've decided I want to go to the hospital, so how do I get there? Okay, now where do I go? Not how do I get there, but where do I go? Yeah? So you've chosen the facility. We don't have an effective ambulance service that you can call and they'll come and pick you. And if you're lucky to get one, they may not even as effective as you may imagine. Then there is lockdown, meaning that public transport is not available at night. The taxi guy may not be very much willing to come down to your route where you are living. Maybe there's a lot of insecurity there. Yeah. So there are family values, which again, I think Ashley had also alluded to. So the husband may say, no, you wait till morning. I can't take you to the hospital now. Yeah, there is COVID. I don't want to be caught by the police outside there. So these are some of the problems that our women have been encountering. Then you overcome the two. So you make up your mind, you identify a facility, you get your cab, you pay, your husband is very cooperative, willing, brings you to the hospital. But when you reach the facility, you don't receive the care that you need. So again, I think I like Ashley's story because she talked about being told that people who come here actually die. So you reach a facility and you don't get the care you want. Yeah. And how did COVID perpetuate or increase this? You find that most facilities actually allow their staff to go away early, and fewer people were available at the critical hour. So you find very skeleton staff. Some actually closed down because the numbers were not meeting the demand to open them 24 hours. Then there was lack of resources and medication, because again, with COVID, we tended to put most of the resources in managing COVID patients. So you'll find that oxygen will be prioritized to the ICUs, oxygen will be prioritized to those patients who need it. But you forget that the pregnant woman coming with eclampsia may also need oxygen. So you go to the maternity and the oxygen is lacking. Yeah. Then we also lacked initially, at least to start with, obstetric protocols specific to COVID, because women presenting with COVID are quite different. They have much more increased risks, and they are at much higher risk of dying than a woman who is not pregnant. So if we cannot manage them like any other COVID patient. So once you reach your facility, these are some of the things that COVID impacted, whereby there were no protocols specifically for that. Maybe even some staff initially would shy away from going to attend to that patient, despite even having the PPEs. So these are the true challenges that we experienced or we're experiencing on the ground as a result of COVID. So you can see COVID has kind of eaten into the 3 delays of maternal care. And actually, you'll not be surprised that when statistics starts rolling out in a couple of months, you'll see that actually more maternal death or even our maternal mortality ratios may have gone much higher during this period. So this chart that I will summarize all this. So there are different drivers that will compromise maternal health in high-risk patients, and preeclampsia and hypertensive disease being part of this. So what I call the basic drivers, the underlying risk drivers, and then the intermediate risk, and then the ultimate event that happens. So the basic risk drivers are looking at what I call deprioritized context and compromised barriers, whereby there's been a diversion, policy diversion. We've had so many deaths in many of our public hospitals, but I've never seen meetings being held as extensively as they've been held during COVID times to address this. I'm not trying to belittle this, but what I'm saying is, in the context of COVID, we've already, those who have been forgotten for most, and which are pregnant women, are even forgotten even more. So the policy diversion is now into COVID. Everything should be spent there. Half the budget is going there. And this leads to a lot of inequity. And when that happens, I think maternity care tends to suffer more. Then that leads to, then there are the underlying risk factors. And these are at different levels. You see, as a result of COVID, there's been a lot of economic shifting. So there are reduced incomes because people have been sacked. People are working on a part-time basis or shift basis. Salaries have been slashed. And these are people already poor. Businesses have been shut down because of the lockdown or less operating hours. So there's increased poverty. There is reduced spending power from this. social nets have been interrupted, like our foundation, for instance. We can't be able to do the advocacy work as effectively as we wanted. And then education has been cut down. Remember that in our society, schools form a very key part in empowering the society. So people learn a lot from school. By going to school alone, actually, some will get food. So all these have been interfered with. And what does this lead to? It leads to poor qualities. You have no money, you can't buy medicines. So even if I told you to buy labetalol or aldomate, you'll not be able to buy. Your priority will be to buy food for your family. You will not visit the hospital because most of our facilities are paying, so you don't have the money to pay for that. Community health workers who would visit you and find out those who are maybe getting a lot of swelling and tell them to go and have their blood pressures checked will no longer visit. And then there's limited care and restricted access to health services. This is because fewer people are visiting, the antenatal coverage will be reduced, the drugs are not as many as they used to be, maternity beds are lacking, and sometimes because there's even shift of patients when there's an influx, so that some of these beds are used up by the very sick COVID patients. So you find that these limits, they already restrained the resources. And then lack of resources and all this are also leading to other things at home. Don't forget that sanitation, clean water, healthy diet are very important parts of quality maternal care. So in the end, you end up with poor compliance to medicines, higher incidence of disease, longer duration of these diseases, and then this will eventually have a long-term effect, which I'm calling intergenerational transfer. So we're going to see that in future, we are going to have many more preterms being born, and this is going to have an impact on future maternal mortality and the general well-being of the society. So in brief, I wouldn't go so much into the science of COVID-19 and hypertensive disease in pregnancy, but yes, there's been a lot of association that has been found. There's been a link between pregnancy-induced hypertension, HELP, and many other factors, preterm labor in pregnancy with COVID, direct association. And I just quoted this very recent study. It's called the COVID-19, which I think inter-COVID study, which was led by Oxford, but it was in many countries, African countries included. And there was about a 1.5 risk of developing pregnancy-induced hypertension in women who had COVID compared to those who did not have. And then about 1.8 risk of developing preeclampsia, eclampsia, or HELP syndrome in those women who had COVID compared to those who do not have. So you can see that we already bear the burden of this disease. And now if you put COVID, which is increasing this rate by about 2 times, then you can see it's a very significant effect on women's health and also health resources at large. So there's also the effect on treatment. And these are just some of the things I want to let you know, that in pregnancy, especially if you're beyond 28 weeks, it's very difficult to manage, especially those who need ventilation. And sometimes it may lead to having to make a decision to deliver these babies early. And that is why in the same study, you find that there was about 2%, almost 1.5 risk of having a premature birth if you had COVID compared to if you did not have. And then there's a higher increase of severe disease. So if you're pregnant, you are more likely to have severe disease if you get COVID compared to if you're not, and especially again in the 3rd trimester. And all these complexities of pregnancy and ICU care, because we try to balance between the health of the baby, the fetus, and the health of the mother, sometimes having to compromise the health of the baby at expense of that of the mother. So this leads to a lot of neonatal death and NICU admissions. And again, in our context, we do not have enough resources to handle this. So you'll see COVID will has been creating and will continue creating a lot of strain because the disease is still there with us, unfortunately. And these are some of the things that we'll have to learn to work with. So what is the way forward? How do we get our way out of this? Do we just sit down and complain the way I'm doing? No, we need to have some framework on how to get out. And the first thing is political will. I know most people I talk to say I don't like politics. Politics is a dirty game. But if there are anyone here who are in policy, they'll know that at the top of the ladder is political will. Without it, you can't get anywhere. So you have to engage the politician. And I'm encouraging even these advocacy groups we're having to really engage the political class, because these are the stakeholders, they're the ones who drive policy. And you cannot be able to implement much without policy. So we need to engage the policymakers and do a situational analysis in our institutions, in our communities. Foundations like us, we are supposed to see what impact this has had and put it in writing, and then sell it out and market it to the policymakers. Then we have to invest in education. And more importantly, I'm not afraid to say this, that of the girls. I think the girls need to be educated more. We need more women empowerment, as the men in the group may accuse me of having been bought, but that is a fact, because once we empower them, then we are going to reduce the impact of this disease. It's the women who are being tested, at least I'll say in Kenya, more than the men. So we can see the women are the ones who are driving the whole agenda. And then, of course, improve living conditions, because these are very important for maternal health in general. Then there's some other indirect health sector things we have to consider, things like family planning, contraception, child spacing. As we were told earlier, there's a need for spacing, let's say 2 years after preeclampsia, so that you reduce the risk of actually getting severe disease in future pregnancies. And then lastly is access to maternity and newborn care, ensure early screening and identification of women at risk, especially during this time. We shouldn't neglect pregnancy during COVID, and ensure that we have timely referrals and improve our newborn care facilities. So all this, unfortunately, again, is a cycle. All the other points will still go back to the policy makers and stakeholders decisions. So what am I saying in short? I hope people are still there. I wish I could see. What I'm saying in conclusion is that COVID-19 has had a great impact. It's both direct and indirect on maternal health, directly or through other indirect means. And COVID alone, 19, has actually been shown to increase the severity and outcomes of hypertensive disease in pregnancy specifically. And there is need for joint efforts through groups like this, so that you can be able to mitigate the effects of COVID on hypertensive disease, and not that alone, but on the maternal health in general. Thank you very much for indulging me, and I thank you very much, the organizers, for having me for this conference. Asanteni sana.
Thank you very much, Dr. Sikolia, for a refreshing presentation. And I also like to confirm to you that about 65% of the people are still here. So you were talking to people, even though their videos are not on, but yeah, some of the people were still here. And I also want to thank you for giving us a very practical presentation on how exactly COVID-19 is affecting the quality of care. Because we've had excellent presentations today from all the speakers, and we are hopeful, we are still hopeful that we can be able to achieve quality care. But now with this presentation, it's so clear that despite all the efforts that we are going to engage, or we've been engaging in, if we sort of leave out COVID-19 and its impact, which is not temporary. I mean, we've seen with projections that we will stay with the economic and health impacts of COVID-19 for a long time after the pandemic has finished. So I'm really glad that you showed us through in a practical manner how we should take this into consideration to possibly be able to still achieve optimal care even under these conditions and going into the future. So I have we have two questions that I'm aware of. The first one is for Dr. Ingrid, and then the second one is for you, Dr. So I will start with Dr. Ingrid's question. The other one she has already answered in the chat. And this question is, are these long-term complications caused by HDP or caused by the risk factors that also increase the risk of hypertensive disorders in pregnancy? Dr. Ingrid, will you please take that question for us? Thank you.
Sorry, could you just ask the question one more time?
The question is, are the long-term complications that we see caused by HDP itself or caused by the risk factors that also increase the risk of developing HDP, hypertensive disorders in pregnancy?
So that's a good question, which we might not be able to answer completely at this point. Of course, the fact that they share risk factors means that it could just be that this woman already has the risk factors for NCDs. And then, as I said, the pregnancy just does allow us to have a peep into the future. There are some theories that preeclampsia itself or hypertensive disease of pregnancy itself can alter the vascular system in the women who have suffered, and that now further predisposes them for NCDs. But that's an answer, that's a question that is yet to be fully answered. We don't know. You remember there's so much we don't know about preeclampsia yet. Since I became a doctor and since I started working in obstetrics, a lot has come up, which is great, but we are still a bit in the dark about some things. But the main sort of theory by the one who postulated about the cardiovascular system being the actual culprit thinks that it's the sort of the poor cardiovascular reserve in the first place that now increases the risk of preeclampsia and NCDs. Yeah. So not a completely clear answer we can give on that one at this point.
For the answer, I think a lot of people can agree that there's still a lot that needs to be done, a lot of research questions and clinical, even public health questions that still needs to be answered. And this is a perfect way to start answering those questions. And then the last question is for you, Dr. Sokolia, and this participant would actually thought that maybe a solution to the first delay that you discussed in your presentation could be to set up a phone service so you can call a doctor to discuss whether you should come in or not, if in this case you are not sure if you need to go to the doctor or not. And then she's actually wondering if there are any kind of interventions, specifically in Africa maybe, which maybe is exactly like that or different that you have come across in your experience.
Thank you. And maybe just before I answer, to back up Ingrid's that question, I already encourage the audience to look at a TED talk by someone called Professor Baski. I think you can get it on YouTube. Just look for TED Talks. He's really put, I think he's unfronting theory and really put it in a very simple way that you can understand. So yeah, to answer the question about, it's true. The issue of phone services, I think are country dependent. And I think if I'm not wrong, in Kenya, there's a hotline, at least in Nairobi, which pregnant women can call if they are in need of a service. Whether it's effective, I don't know. But there have also been other private initiatives by colleagues who have come up with a kind of an Uber service for pregnant women. But these are not government driven. They're mainly by advocacy groups and intervention, people who have interest. So yeah, sometimes you can't wait. The phone service is important. Maybe sometimes you can't always wait for our governments to do things. So advocacy groups like this ones actually also come in handy. They can help develop hotlines and link up women, especially those in hard to reach areas, with dedicated volunteer obstetricians who can help them to overcome the first delay.
Thank you. And just one last question. I know I said the other one was last, but this is a burning question that I think we all want to know the answer for. And probably it's not yet clear because of ongoing research. But this question is on whether the increased risk for pregnancy complications is due to the virus itself, or is it more about the delay in getting care?
Yeah, that's a very brilliant question, actually. Yeah, because yeah, you can look at it another way, and I think that will require a lot of epidemiological study to be able to answer that. For sure, in some countries, there's actually been a positive effect of COVID, whereby there've been a reduced incidence of spontaneous preterm birth during the lockdown. So whether staying at home and maybe the works we do in office contribute to this, we do not know. And that's true. The virus could have an effect on pregnancy, and also the other, what will I say, effects of the virus on the social well-being and normal daily life can also have an effect on maternal mortality. So it could be either way, but it's for epidemiologists to be able to tell us that. But that's a very brilliant thought, yeah.
And I completely agree that it could be both the biological processes that happens in the body in response to the virus entry, and also the social aspects of being in this kind of environment may potentially both contribute to the increased risk. So now with that as the moderator for the conference, I'm going to conclude my part and then hand over to someone to close the conference. So, I mean, I don't have enough ways to express how excited I am. I'm feeling so excited because of all the presentations and the hope that came from the presentations when looking into the future. I mean, it's clear that advocacy work has already contributed a lot by promoting awareness and supporting women. And I mean, by also just sharing their stories, they encourage each one of us to do something about hypertensive disorders in pregnancy, which is really a burning issue. And I think one of the major public health concerns, not only in Ghana, Kenya, or the work that has been presented here, but in the whole African continent, because some of our health resources are dedicated to infectious diseases in a level that there's just a little bit left for maternal and fetal health. So the presentations were really excellent. I've learned a lot myself, and I'm encouraged and hopeful that there's more that we can do if we work together. We saw the challenges that are there in communicating and working together, but we also saw the things that we can actually capitalize on to promote a holistic approach in preventative measures and management of hypertensive disorders in pregnancy. So I would like to thank all of the speakers, all those people who were contributing to the chat, the participants asking questions here on Zoom, and those joining us from Facebook. It's been amazing, it's been insightful. And from myself, thank you very much. And I hope you will all have a great afternoon and stay safe throughout the pandemic. And one day, maybe we can be able to meet and have this conference in person. I will now just hand over to Ms. Sylvia Mwichuli to please close the conference for us. Thank you. And as Joyce is also posting in the chat, you are more than welcome to take a minute, each one of you, and post for us, what did you take out from this conference? I had my take-home message, so yours you can also post in the chat and also on Facebook. We would really very much like to hear what your take-home messages are for this conference. Sylvia Michuli, is over to you. Thank you.
Okay, thank you. Hello, everybody. And I think we should really appreciate Labour for the great moderation. Labour, you've kept us going for all these hours. Thank you for keeping the energy up. I think it's been awesome having you as our moderator. I wish we could, if we were in a physical conference, we'd be able to clap and appreciate for you. But thank you so much. I just want to thank everybody for attending, all the wonderful speakers for all the practical presentations. I think it's been awesome. I've seen on the chat, people are saying they have learned a lot and that it was a wonderful conference. I just want to summarize the discussion today into 6 major action points. And I think this is the first. So we are hoping that during the second conference, some of these action points that we're talking about and that we have been given will actually come to fruition. So I think the challenge is with the 2 host organizations to try and ensure that whatever we have discussed comes into something. So the first issue I think that we have all agreed on is that there is need for stronger multi-sectoral partnerships. We've talked, I mean, most of the speakers have talked about this, the need for the fact that I think there was one speaker who said we cannot do this alone. I think it was a lady from WHO. We actually need to really build strong partnerships towards for action. And then the second thing was that we need more research. I think when all the speakers from Africa were talking, they kept alluding to the fact that we really do not have enough research. And I think this is an area where we can build strong partnerships between the organizations that are coming from the West and those working in the South. So I think this is an opportunity, Dr. Maggie and others, for us to see whether there are opportunities to do some serious research so that we can go for an evidence-based implementation. I really, really want to thank the speakers that have talked about the need for community engagement. I think even here in Africa, we have had over and over again in this session that there's not enough of it. And linked to this is a strong communication strategy to really get people to understand the issues we are concerned about. There's the issue of policy and the need to drive strong political will and policy support. I think Dr. Sikolia in the last presentation did a great job of emphasizing this. And I think it is a very important issue. For the 2 host organizations, the need to build strong advocacy campaigns. And I was very happy, somebody on the chat has actually talked about an opportunity to build a strong Pan-African-wide advocacy campaign on this issue. So I think that's one action point we can pick up immediately. I'm also very, very pleased by the proposal to push for increased budgetary and institutional support. This is an area that we can work together jointly to see, because without resources, you can hardly do anything. The institutions do not have enough resources. The hospitals do not have, they cannot provide quality of care. And I think our professor from Ghana really elucidated very well what needs to be done in this area. So there have been many recommendations and many takeaways, but the last one that I think we really need to think about is how to leverage on technology. There was a proposal about how we can use ICT, how we can leverage on the mobile phone penetration across the continent, and how we can just build strong health systems around the technology. In conclusion, what I really liked about the conversation today is the fact that we are going to look at the health sector as a system and figure out how we can leverage on that system to make life better for pregnant mothers and children in Africa. So I want to thank everybody, and just to tell everybody, thank you so much for making the time. Our hope and prayer that this is just the first and that we'll be meeting you next year for the second. And as we move forward, we hope that Africa will be a much better place for everybody. So God bless you. God bless everybody who attended, and thank you so, so much for making the time to be with us today. My name is Sizwe Mkhwanazi, and I'm a board member at the Zuri Zilani Foundation, one of the co-hosts of today. So thank you, everybody, and God bless. Goodbye, everybody. Have a good weekend.
Bye-bye. Thanks, Sylvia. You too. Bye, everyone.
Bye, everybody.